कुन्देन्दु तुषारहार धवला या शुभ्रवस्त्रामृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युत शङ्कर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा।
Good evening, everyone. It gives me immense pleasure to welcome all of you to this 22nd episode of the O2S Obstetric Masterclass web series. So today we have a galaxy of faculties along with us, and I'm happy to announce over here that we have had 5,000 plus delegates in all the programs over the last month that we have conducted. And it has been a web series that people have really waited for. And thanks to all our delegates who have joined us even today, in spite of it being a new year and in spite of a lot of festivities that's happening around the country. So wishing all of you a very happy new year. To start off with this session today, I would first of all like to thank Dr. Jaideep Tang sir, who is the convener of this program, and Dr. Parikshit sir Tang, who is the co-convener of this program, and my co-moderators Apurva, Niharika, and Rohan. So the program that we have today are two excellent talks by Dr. Jaideep Tang sir on fetal distress, a clinical approach, and by Dr. Charmila ma'am on the rational use of iron in pregnancy. And then we have a wonderful panel discussion on fever in pregnancy. So first of all, I would like to welcome our esteemed chief guest of today's program. It's Dr. Sadhna Desai ma'am. Ma'am is a senior consultant at the Breach Candy Hospital and Desai Clinic in Mumbai. She has been the past president of FOXY. She's a pioneer in the work of fertility services in India and has received many accolades from various organizations. So ma'am is like a motherly figure for us, and everyone looks forward to her. And when she comes as chief guest to the program, she brings in a lot of energy, and the way she talks gives us a lot of enthusiasm. So I would request ma'am to tell a few words, a forward-looking statement and a few words of encouragement for all of us.
Andy, before you speak, Dr. Sadhna Desai, if I may interrupt here, I have actually had the pleasure and privilege of knowing Dr. Sadhna Desai literally since I was a very small child. I have actually grown up seeing Dr. Sadhna Desai, right through my childhood years, my teen years, and my adult years. Although I think there are some people who might say that I haven't actually grown mentally that much, but physically for sure. And I think what is really admirable about Sadhna Aunty, I'm going to call you Sadhna Aunty, it's very difficult to call you Dr. Sadhna Desai. What is particularly admirable about Dr. Sadhna Desai is that every time an IVF cycle happens in India, I think it behoves us to keep in mind that the first IVF cycle in the private sector was actually done by Dr. Sadhna Desai and Dr. Nehru Ansotia. And I think from those very early beginnings, IVF has now grown to what it is in this country. And I think every time we actually do an IVF cycle, we should remember that the beginning of all this was from the fertility clinic of Dr. Sadhna Desai and Dr. Nehru Ansotia. And I know that Dr. Sadhna Desai is very well known for her fertility work, but perhaps what is not equally well known is her passion for women's health and her extraordinary role in the EMOC project of FOXY. She has led that project for so many years. It's really been the most successful project that FOXY has led, which has led to an institutionalization of EMOC in so many medical colleges and government institutions. In fact, there was a time when the government of India said that if Dr. Sadhana Desai is not leading this project, we are going to take this project away from FOXY. So thank you very much, Sadhana Aunty, for taking the time to be here. And please, we would love to hear from you. Aunty, you're muted. Can you unmute yourself?
Better? Can you hear me?
Yes, but we cannot see you now, Aunty. તમે stop video કર્યો હશે.
Okay.
Fine. Yes, fine. Thank you.
So thank you, Jaideep, for your kind words. I have seen you grow from your childhood till today. I know your very good qualities you have inherited from your father, who was a very good friend of mine. And I see a great future for you because you have very meticulous and very honest in your work and very sincere and dedicated. And I wish you all the best for all your future endeavors.
Thank you. Thank you.
So Dr. Jaideep Tang, Dr. Parikshit Tang, and Dr. Priyankur Roy, I thank you all for inviting me to give the introductory remarks on the obstetric topics which are going to be discussed today by the various experts. Rapid advances in the field of medicine have brought about many changes in the diagnosis and management of medical disorders in pregnancy and labor. Better understanding of the physiological changes that occur in pregnancy, availability of safer pharmacological drugs to treat medical disorders in pregnancy, and sophisticated and highly sensitive image intensifying equipments to study the growth of the fetus in uterus have led to reduction in maternal mortality and perinatal morbidity and mortality. In today's webinar, 3 obstetric topics of great clinical importance are going to be discussed: fetal distress, anemia in pregnancy, and panel discussion on fever in pregnancy, a very hot topic in the current era of COVID pandemic. Fetal distress is a very broad-based term which can be used for many clinical conditions. Is indicated that fetus is becoming hypoxic, which may lead to intrauterine fetal device, or it may lead to neonatal mortality or neonatal morbidity, especially the neurological damage of the newborn. When signs of fetal distress are noticed, immediate delivery has to be considered. Fetal distress in labor can be detected by electronic fetal heart rate monitoring and by intrapartum fetal scalp pH measurement, which is not available in many labor ward. The electronic fetal heart rate monitoring is not a good predictor for fetal pH. Besides, there are many variations in the fetal heart rate rhythm and pattern, which are of different significance. Therefore, a thorough knowledge of fetal heart rate monitoring is required. Otherwise, EFM can raise false alarm, leading to unnecessary increase in the rate of operative vaginal delivery or a cesarean delivery, causing paradoxically increase in the maternal or fetal morbidity, a term called as obstetrical paradox. Over last several decades, technical advancements have brought forth a lot of understanding of biological and applied sciences. In high-risk cases, clinical signs of impending fetal hypoxia and placental insufficiency can be detected by strict antenatal fetal surveillance. This may help to plan an early intervention of delivering the fetus in consultation with the neonatologist. Sometimes fetal distress can occur unexpectedly due to sudden placental disruption or due to hypovolemia or hypotension or cord compression. One must be alert in timely detection of fetal distress. The next subject to be discussed is the anemia in pregnancy, which is a global health problem but seen more often in developing countries. The Indian National Health Survey 4 shows that 50% of the pregnant women are anemic, while some degree of hemodilution resulting in anemia is part of normal physiological pregnancy changes. Iron deficiency anemia can have serious adverse health consequences for mother and her child. Thus, it is critical to distinguish iron deficiency anemia in pregnancy from physiological anemia, as well as to identify other less common cause of anemia in pregnancy that may require treatment. Many strategies are developed to tackle anemia in pregnancy, out of which iron and folic acid tablet supplementation is considered best in Indian settings. Latest National Anemia Control Program has recommended that pregnant women be given 60 milligram of elemental iron as prophylaxis because newer evidences are coming which show that excess of iron in body can have adverse effect. Now that more than 2 decades have passed since Indian National Anemia Control Program is in existence, the prevalence of anemia in pregnancy has still not changed. This may be due to the low bioavailability of iron in Indian diet or due to presence of factors decreasing iron absorption or due to infections like hookworm or malaria or non-compliance of taking iron by women due to pharmacological characteristics of iron tablets such as unappealing taste or smell or due to gastrointestinal side effects. Newer and better pharmacological iron preparation with less side effects are now available, and more effective modes of iron supplementation other than oral routes are also recommended in severe anemia. Now the last is the panel discussion on fever in pregnancy. SARS-CoV-19 is a newly discovered, highly contagious and virulent virus that caused innumerable deaths of human beings and has caused the world to come to a standstill. COVID pandemic has made everyone worried about its effect on pregnant women and its effect on her unborn child. Today, many fever clinics are being established in India to diagnose and to treat fever and to differentiate fever due to COVID-19 infection from other causes of fever. It is very appropriate that today's expert panel of obstetricians are going to discuss management of this deadly infection in pregnant women and its effect of various antiviral therapy used for treatment on pregnant women and her fetus. Besides COVID-19, there are other common causes of fever which can cause threatening complications to mother and her fetus, like malaria and dengue fever. Fever in the first trimester of pregnancy due to chickenpox or rubella can also have adverse effect on developing fetus. I am happy that the subject of fever in pregnancy will be discussed at length by a panel of experts. Today's webinar is very interesting and of great clinical importance. I congratulate Dr. Jaideep Tank and his team for organizing an excellent master class on series of important subjects in obstetrics. My best wishes to the expert speakers and congratulations to the organizers of this webinar. I wish this master class a great success.
Thank you. Thank you very much, Auntie, for your very kind, thoughtful, and comprehensive, forward-looking statement. It's always such a pleasure to hear you and learn from you. Thank you very much again for making the time to be here. Priyankur, can you please take it forward?
Thank you so much, ma'am, for this wonderful words, ma'am. It means a lot to us, and this words of a forward-looking statement summarizing all that is going to come up is going to be very, very useful to all the delegates who are present today. Thank you, ma'am, for that. So next, we come to the academic session proper. I would first of all like to invite Dr. Jaideep Tank, sir, for his talk on fetal distress in clinical approach. And sir, we all know him. He's currently the General Secretary of Secretary General of FOGSI, past President of the Mumbai OBGYN Society, Chair of the FIGO Committee for Safe Abortion. And apart from all this, he has been instrumental in starting the online elections for FOGSI, which has gone a long way and is very, very useful, I would say, and also very convenient for all of us who are there in FOGSI. And also, he is one person who is instrumental in most of the collaborations that is there in between FOGSI and the government as well. And recently, the MTP amendment, he has been played an instrumental part in that as well. So I request sir for his very important talk now.
Thank you. Thank you very much, Priyankur, for that always kind and generous introduction. And can I ask if my slide is seen and I'm audible?
Yes, sir. Both, sir.
So let me again thank Dr. Sadhna Desai for her always thoughtful and very clear thinking message. I am going to speak on fetal distress, and then we are going to have Charmila speaking on the rational use of iron in pregnancy. Charmila is one of my closest and oldest friends in FOGSI, and she had done a remarkable amount of work when she was the committee chair. And I remember, Charmila, that we had actually got funds from FIGO to do one of the projects, and we had got it published also. So thank you very much for agreeing to be here. The panel, I must say, today has got some real academic heavyweights, if I may say so. There is Dr. Ashok Kumar from Delhi, Dr. Jayashree Gajraj Madam, Dr. Aruna Kumari, Asha from Indore, who has just been elected in the last election. And then there are three of FOGSI's most committed, dynamic, and hardworking chairpersons. Kalyan, a very dear and old friend from Latur, Dr. Anju Soni, who despite all her personal problems has tried and made it a point to attend this webinar, and of course the how do I say, the nightingale of FOGSI, Girish, who has done such remarkable work as the committee chair. I would just like to mention especially Dr. Radha and thank her for organizing that wonderful South Zone Yuva FOGSI. Dr. Radha, I think we got away just in the nick of time before the second wave has really, put things to a halt. So if you will see that number over there, that's 5,372. And that is the number of people who have joined this webinar. That is a screenshot I have taken just 2 minutes back and pasted it on this slide. When we started this series, in the first series, we had an attendance close to 2,800 or 3,000, and that was in November. And it's been a matter of a special sort of privilege, if I may say so, and pride to a certain extent, that every time, every Wednesday, we see a larger number of delegates joining us. And I'm so indebted to all of you who have taken time off and have spent that time with us. And hopefully this series has been very useful to you, or at least somewhat useful to you in your practice. So thank you very much. This is the last of the O2S series, but we are not going anywhere. We are going to be back on the 5th of May for another 6 months, where we will now be covering similar to how we have covered obstetrics. We are now going to be covering gynecology. And that series will be called the G2I Masterclass series of gynecology. The plans are already in place. We have made the programs. Invitations will start going out next week. And just like we had done for this series, we have made the program entirely till the October. And so over the next few weeks and months, we will be doing the G2I again at the same time, Wednesday, 7 o'clock. That pretty much remains the same. So I'm going to speak today on fetal distress. And one of the peculiarities, if I may say so, of whenever we tell a patient that I'm sorry you have fetal distress and you therefore either need a cesarean or an expedited second stage of delivery, and I'm sure this is most people's experience, is that we go out and we tell the patient, you know, that the child's heart rate is dropping and we now need second stage forceps, and lo and behold, the large majority of times, the child comes out crying, and crying lustily, if I may say so, which sort of sometimes makes the patient ask, doctor, you said the heartbeat and all was going down. How come this child is crying so well? I don't think they are complaining. And I think it is things like this which have led to statements like this one which Barbara Harper made. We used to see birth as a miracle and only mess with it if there's a problem. Now we see birth as a problem, and if we don't mess with it, it's a miracle. The fact of the matter is that fetal distress, as Dr. Sadhana Desai said, is really an ill-defined kind of a phenomenon. So today we will talk about the definition, diagnosis, and treatment to whatever extent we understand. Fetal distress, as has been already said, is a poorly defined vague term, and it's essentially used to denote the possibility either of fetal hypoxia and or metabolic acidosis. The thing to remember, and the reason why most babies come out crying lustily, is that even with significant abnormalities in the CTG, the risk of fetal acidosis and fetal blood sampling was only 50%. Moreover, the positive predictive value of an abnormal CTG trace for babies who needed positive pressure ventilation is only 8.7%, and a positive predictive value of an abnormal CTG trace is only 27.4% for all babies with an ABGAR score of less than 7 to 5 minutes. Obviously, this all points to the fact that interpretation of all the markers that we use for fetal distress is extremely important. Birth asphyxia, or as it is now called HIE, is a very broad term. And in current practice, perhaps that event should appropriately be more called pathological CTG trace or acidotic pH to denote exactly what is wrong, rather than a very broad term of fetal distress. Obviously, accurate interpretation of the CTG is very important. So, when do we say there is fetal distress? Two clinical situations. There is either a fetal heart rate abnormality or there is meconium. So, let us look at both these in turn. But first, the big debate about whether intermittent auscultation is better than electronic fetal heart rate monitoring in labor. The answer is that when done in controlled settings, intermittent auscultation and electronic fetal heart rate monitoring, whether you do that electronic fetal heart rate monitoring intermittently or continuous, are more or less equal. In fact, there is data to suggest that if you do continuous electronic fetal heart rate monitoring, the incidence of intervention is much higher. Remember, however, that sometimes it's a false equivalence, and it's a false equivalence because we always don't have situations where there is one-on-one ratio in labor care. For example, to achieve the same results with intermittent auscultation as you would with electronic fetal heart rate monitoring, you would need a 1:1 patient caregiver ratio with intermittent auscultation happening every 15 minutes in the active stage of labor and before and after every contraction in the second stage of labor. I don't know how many of us do that kind of rigorous intermittent auscultation, but that's what the literature tells you. We rely very heavily on the admission test. And there is again good literature to show that if you do an admission test, the correlation with perinatal mortality is actually quite good. We know that when we look at the trace, we are essentially looking at the baseline rate, variability, deceleration, and acceleration, which could be either reassuring, non-reassuring, or abnormal. And it's very useful when you look at a CTG to actually note down each feature and say whether it is reassuring, non-reassuring, or abnormal. Depending on the spectrum of whether it's reassuring, non-reassuring, or abnormal, you classify the CTG into normal, suspicious, or pathological. We have always found it very useful to write on the CTG trace what the finding of the CTG is and not rely only on eyeballing the CTG because that leads you to pay attention to actually what is happening. All this has been reiterated in a FIGO publication in 2015 by Dairis Campos et al. We know that there are certain conditions, maternal and fetal and intrapartum, which predispose to fetal distress. For example, preeclampsia, postpartum pregnancy, IUGR, oligoamnios. Oligoamnios is something I'm always quite worried about. Excessive augmentation, vaginal bleeding in labor, maternal pyrexia, and of course, fresh meconium stained liquor. But when you are talking about the CTG as opposed to the NST trace, it's very important to remember that the CTG has two parts. There is cardiac and there is topo, and the latter should also be carefully noted. There is an unfortunate practice in a lot of places where the topodilometer is simply not put on the patient's abdomen when she is in labor. Remember that you need to have information of both, because whether a deceleration is early, variable, or late actually depends on the topodilometer trace. One of the very important things I'd like to tell you here is that the machines which are available nowadays have got these very high-end sensors. These sensors, if they detect a low heart rate, tend to double the heart rate on their own because they think that they are intelligent. And by doing so sometimes, you may actually be picking up the maternal heartbeat, which may look like this. So this is not a trace of a fetal heart. This is a trace of a maternal heartbeat in an IUFT patient. Remember always, therefore, that whether you're doing an NST or a CTG, it's very important to auscultate with the stethoscope first, because the stethoscope doesn't have a doubling mechanism, and you can fool machines, but you can't fool the human ear. It is, of course, very easy to identify a normal CTG. The important thing is that if the CTG is normal, and if the movements are good, the risk of fetal hypoxia and acidosis is extraordinarily small. We place a lot of importance on fetal movements. If the mother says, my child is moving well, that is extraordinarily reassuring. Whenever you look at a CTG, don't look at only that portion of the CTG. Please see the CTG before, or at least two other CTGs which are there. Otherwise, you will miss out on subtle changes in the baseline heart rate and changes in the variability. We know that accelerations mean transient increases in fetal heart more than 15 beats per minute, lasting for more than 15 seconds. Remember that the absence of accelerations is of uncertain significance. So the presence of accelerations is reassuring, rules out fetal acidosis, but the absence of accelerations is of uncertain significance. What is a very important thing to remember is that accelerations present in the second stage of labor are actually normal. It is normal to have early decelerations in the second stage of labor due to head compression. So if you have a patient who's fully dilated and the mother is pushing and you're seeing accelerations, remove the probe, take your stethoscope, auscultate manually. You might sometimes be picking up the maternal iliac vessels on your CTG machines. Again, decelerations more than 15 beats per minute, lasting for more than 15 seconds, classified essentially in accordance with the tokodynamometer trace. And therefore, there are various kinds of decelerations. Early decelerations are decelerations which look like this. They are mirror images of the contractions. And if you're getting early decelerations in early labor, you need to be cautious. And if you're seeing them in the second stage of labor, more often than not, they are because of head compression. Late decelerations are something that you really need to worry about, and they are called late because of the delayed recovery to the baseline rate. These decelerations could, in various situations, indicate either hypoxia or fetal acidosis, and you should be very cautious before you allow the labor to continue. Variable decelerations are so named because they vary in shape, form, and timing in relation to the uterine contractions. You can see that very classical shouldering in this trace. If you don't see the shouldering, then you should be a little worried because that could actually be a late decelerations. Repeated variable decelerations may indicate oligoamnia. So if you see these kind of decelerations with shouldering and you change the position of the patient, if he's lying supine, make a left lateral and then these disappear, you can be more or less assured that this is because of oligoamnios or some form of cord compression. These are pre-terminal or sinusoidal patterns. They are not seen very commonly, but when they are seen, you really need to be very alert and careful. One last practical tip about CTGs is always look at the paper speed. You can see on top and on the bottom, it's actually the same patient CTG run at different paper speeds. So different paper speeds will give you different appearances. When you have a paper speed of 5 centimeter a minute or 3 centimeter a minute, it's going to look very different from a paper speed of 1 centimeter per minute. If you look at a very broad kind of a CTG where the number of variations or the variability seems to be very low, always take a look at the paper speed, particularly when the paper has been changed by a non-medical person. They may sometimes inadvertently change the paper speed and you will have something which looks suspicious but be not really suspicious. When you're looking at a suspicious trace, you have to look for cycling because you know that there is something called fetal sleep, and if there is a reduced variability for more than 40 minutes, then you should consider using either FAST, which is the fetal acoustic stimulation test. I remember in Wadia Hospital, when I was a first poster, I had done these studies with Dr. Faizad Damania. And if the fetus responds with a startle response, as they say, then you know that this fetus is unlikely to be hypoxic. If the FAST is negative, if fetal blood sampling is available, you can get it done. But if it is negative, you should hesitate to continue the labor. So responding to a suspicious or a pathological trace does not always demand an immediate cesarean. You can perform such simple measures which are outlined over here. You can give terbutaline, but remember that if there is a very significant fetal distress and you're planning a delivery, it's better to deliver the child faster than give terbutaline because that terbutaline will come back and bite you in the form of PPH in these circumstances. So use it very sparingly, very selectively. Changing position and hydration, stopping oxytocin infusion are other measures. There is actually currently no evidence to suggest that maternal oxygen administers improves perinatal outcome. In fact, a recent review has suggested that it may in fact be detrimental to the fetus. So if you have a grossly pathological CTG, 3 major accidents, abruption, cord prolapse, and scar rupture should first be ruled out. If they are ruled out and if operative vaginal delivery is not feasible, then a category 1 cesarean section, that means a cesarean section done quite fast, should be used. If those three accidents are ruled out, follow the 3, 6, 9, 12, and 15-minute guidance, where you wait for 3 minutes, await delivery, move the patient to the theater by 9 minutes, surgery within 12 minutes with the aim of delivering the fetus by 15 minutes. Reduced baseline variability prior to Brady is associated with a poor outcome. So that is about fetal heart rate and how we take action on it when we suspect an abnormal CTG. The other part of the fetal distress spectrum is meconium. And as this child is saying here, meconium happens. It's no surprise to learn that if you look at the intrapartum care guidelines, you will see that the large majority of adverse outcomes actually occur either because of abnormal CTGs or meconium aspiration syndrome. Meconium aspiration, meconium staining of amniotic fluid is actually quite common, 10 to 20%. However, fortunately, meconium aspiration syndrome occurs only in 2 to 5%. Remember, it is not the meconium which is present at the onset of labor, but the meconium which comes when initially the liquor is clear and then you start seeing meconium. That is really a meconium that you have to worry about. Degrees of meconium staining are significant and light. There is nothing like mild, moderate, severe. It's either significant or it is light. Meconium by itself, the presence of meconium by itself has been hypothesized to actually cause detrimental neonatal outcomes, and the risk is supposed to be independent of everything. It is hypothesized that there are substances in meconium which actually cause vasoconstriction. So, as I already told you, primary versus secondary meconium. Secondary meconium is independently associated with much poorer outcomes. There is also the fact that when you see meconium in SGA infants particularly, you need to take action much faster. So if the patient is not in labor, you could induce. In labor, you could do continuous monitoring, and if no signs of fetal distress, augment labor. These are the guidelines. In practice, I know that when you see meconium, it's usually a signal that that patient needs a cesarean section. Of course, if you have meconium staining along with abnormal fetal heart rate tracings, you are going to get poorer outcomes. Remember that amnioinfusion does not prevent meconium aspiration syndrome. There may be a very, very small place in the antenatal period, but in labor, there is really no place for amnioinfusion. If you're dealing with meconium stained liquor, please always have a pediatrician in attendance at the time of delivery if it is possible. Finally, meconium stained liquor alone is not associated with an adverse neonatal outcome. It is when you have either an abnormal heart rate, oligoamnios, or these kind of problems that the worst outcomes occur. So if you have meconium in labor at the time of ARM, look at the parity, look at the dilatation, look at the fetal growth, and then decide the management. For example, an approach to a second para at 9 centimeters is going to be dramatically different from your approach to a meconium stained amniotic fluid for a primey at 3 to 4 centimeters. Finally, if you are going to do a cesarean for fetal distress, a few practical tips. Remember, if you are going to do a cesarean for fetal distress, as soon as you tell the relatives and the patient that there is fetal distress, the clock starts ticking. It is my advice, particularly for those who work in nursing homes like we do, that you tell the patient that there is fetal distress after arranging the anesthetist and making sure that the anesthetist is on the way. That way, your decision to delivery time will always be less than 30 minutes. If you are going to use anesthesia, my recommendation would always be spinal with a pencil point or a 26 gauge needle. A practical advice, hypotension or high spinal are disastrous after a spinal anesthesia. A sincere advice is please be washed up before spinal anesthesia is given. Our practice is to put betadine on the beta scrub on that patient, cover it with a plastic drape, and then shift the patient to the OT. Because typically in a fetal distress, you'll be in a hurry to deliver the patient. And when you're in a hurry, that is when you might get surgical site infections. If you do this way, cover the patient with a plastic drape, scrub with betadine, cover with plastic drape. By the time you start the cesarean, the betadine has had an adequate time to act. Let me reiterate, and this is one of the books which has influenced me very greatly. This is the time and motion studies. And what essentially it says is that you don't operate fast by operating fast. You operate fast by reducing your number of steps. And that is what is known as time and motion studies. So don't be in an undue hurry, but be quick by reducing the number of wasted movements. A lot has been said about this. Suffice it to say that only 10 to 15% of all cerebral palsies are because of intrapartum events. Most cerebral palsies actually occur because of antepartum events, and that is something which needs to be kept in mind. So at the end, why intrapartum monitoring? It's to provide reassurance, and it's to identify that fetuses are being adequately oxygenated. So although there is insufficient evidence from RCTs to demonstrate any one form of intrapartum fetal monitoring reducing poor outcomes, the entire package or the environment of the labor room where fetal monitoring is practiced routinely constitutes important evidence that intrapartum monitoring does make a difference. This is something I had written, I think, in 98 or 99 in the textbook, which was edited by Dr. Usha Krishna and Dr. Daftari. And it was my thought at that time, and I think this is still true, that most literature focuses either on predicting or detecting fetal distress. There is, however, nothing that we can do to actually treat the fetal distress per se, and it will probably need a paradigm shift in evidence before we can actually think of a treatment for fetal distress more than simply just terminating the labor and delivering the fetus. Thank you very much. I'm sorry, I think I overshot by around 5 minutes today. Priyankar?
Thank you so very much, sir, for such a wonderful talk. As usual, your talks are all clarifies the topic completely. And thank you so much for doing that again today, sir. Thank you so much. So now we move ahead with the next talk. So the next speaker today is Dr. Charmila Ayavu ma'am. She is a thorough academician, was an ex-chairperson of the Clinical Research Committee FOXI, president of the Menstrual Hygiene Consortium, and she is the ICOG Governing Council member from 2021 to 23. So nowadays, there are seldom days where we do not see ma'am imparting knowledge, not imparting knowledge in any of the webinars. She's there every day almost in some webinar or the other with talks or either moderating a panel or as a panelist. So it's a matter of immense pleasure to have ma'am today with us, and she's going to talk on the rational use of iron in pregnancy.
Thank you, Priyankur, for this kind introduction. And let me remind you, I see you also in the same webinars. We are there always now. I'm extremely thankful to Dr. Jaideep Tang for giving me this opportunity to talk in front of such an august audience, which is Dr. Sadhana Desai ma'am. And as ma'am said, we have been talking about iron for almost decades, but still we have not mastered the management of anemia. And that's why 50% of our women are still anemic when they become pregnant. So let me talk about the rationale in the use of iron during pregnancy, because we have got some problems in managing, and that's why we are not able to help our women beyond a point. So as ma'am said, the global prevalence of anemia among pregnant women is almost 40%, and that's according to the WHO in 2016. But in India, the prevalence is around 33 to 89%. And as ma'am said, the NHFS survey, it is almost 50%. Even though there's a drop in the prevalence of anemia from NFHS 3 to 4, still we are still around 50%. And iron and nutritional deficiency contribute as major causes to this disease. The physiology of RBCs and iron, we need to know before we go on to the talking about the treatment with iron. Erythrocytes and all the precursors will require large amounts of iron for the production of both heme and hemoglobin. Iron is actually central to the hemoglobin structure and function. And when we talk about the demands of iron in pregnancy, the mother will be utilizing for the baby, for the placenta, for the blood loss at delivery, and the total gross which she'll be needing is almost 1000 to 40 milligrams. But she'll be actually gaining some also, and that's around 610 milligrams, and that's from the absence of menstruation in pregnancy and the postpartum decrease in red cell mass, which will give her almost 450 milligrams of iron back to her. So the total net iron demands for a person who's pregnant is almost 630 milligrams. And to this 630 milligrams, you need to add 300 milligrams for her iron stores if you want to prevent a negative iron balance. And majority of the iron transfer of the fetus will happen around the second and third trimester. And that's why physiological anemia also becomes very common after the first trimester. And the daily requirement for iron in the first trimester is only 0.8, but it becomes almost 7.5 milligram per day in the third trimester when the baby will be needing more of iron for its own growth. So how much iron is actually absorbed from an average Indian diet? It can vary from 0.8 milligram per day to almost 4.5 milligram per day, depending on the type of staple which a person is used to. And iron absorption from the duodenum will also increase in pregnancy to compensate for the need. And 1.3 to 2.6 milligram of elemental iron is absorbed from a pregnant woman during pregnancy. But the problem is with an Indian diet does not provide enough iron to the mother and the baby. So do we really think that all pregnant women will need iron supplementation? That is, even if she's not anemic, will she need iron supplementation during pregnancy? And for that, there was a Cochrane review in 1999 where they found out that only 20% of fertile women had more than 500 milligram of iron stores. 80% had either between 100 to 500, and 40% had no stores at all. So actually, when you think logically, all pregnant women will need iron supplementation because they do not have enough iron stores when they even start the pregnancy. So iron supplementation will cause a reduction in anemia. There are many studies for that, but there are no studies to say how much it will reduce the severity of the anemia which is going to happen during pregnancy. And there are no well-designed trials for that. But there are studies which say that even if you don't give daily, a weekly supplementation is also equally effective. And any form of supplementation with iron you give to a non-anemic pregnant woman, it will cause a 73% reduction in her becoming anemic during her pregnancy. So in a non-anemic woman, a person who's got a normal hemoglobin, you need to give her at least 65 milligram of elemental iron per day. And for that, you know that almost 10% will be absorbed and she'll get 6 milligram per day, which will compensate for her RBC mass as well as for the baby. But even for a person we are supplementing, and in spite of her not being anemic, you need to check her hemoglobin after 8 weeks because you need to know whether she's becoming anemic in spite of taking iron appropriately. And the preparations which are available to provide that elemental iron, the best and the simplest is ferrous sulfate always, and that has been there for decades in spite of the new forms which come. And it provides 60 to 65 milligram of elemental iron in a single tablet, whereas gluconate will provide 37 to 39 milligram, and fumarate will give 107 milligram of elemental iron. There are 3 phases of iron deficiency anemia which we need to know before we start treating a patient. And the first change which will happen in a pregnant woman is a depletion of an iron stores when the need is more than what she has, and that will cause a negative iron balance. And the second change which will happen is an iron deficient erythropoiesis. And the third phase is iron deficiency anemia. So Harrison is the Bible for when you want to interpret the iron stores and the different forms of iron deficiency anemia. So for the iron stores, it can be in the marrow, it can be in the serum in the form of ferritin, it can be in total iron binding with the transferrin, serum iron levels, saturation percentage, the protoporphyrin levels, and the morphology, which will all tell you which will all reflect the iron stores and the amount of iron that the person has. In a person who's having normal iron stores, she'll have 1 to 3 plus of marrow iron. The ferritin level will be somewhere around 50 to 200. The iron binding capacity can go only up to 360. The serum iron will be 50 to 150, and the saturation percentage is 30 to 50, and protoporphyrins are 30 to 50. When she goes on to the next phase of negative iron balance, she will be losing a ferritin from the iron from the marrow. So she'll have a less than 20 value at that time, and the total iron binding capacity will also start increasing because she needs more iron because she's losing all the iron from her stores. When she goes on to the next phase of iron deficient erythropoiesis, a ferritin would have fallen more to almost 15. The iron binding capacity is now increasing beyond 380. The serum iron level falls to less than 50, and the saturation percentage also falls. But the protoporphyrin starts increasing because the precursors are being formed more than the mature RBCs. And when she is in iron deficiency anemia, total iron deficiency anemia, the ferritin would have fallen to less than 15. The iron binding capacity is more than 400. And now you will see the peripheral smear picture of microcytic hypochromic anemia, which will not be seen in the phases of iron deficient erythropoiesis or when she's having a negative iron balance. That's why you need to be very, very careful when you're managing your pregnant patients. So for the ferritin level is the best for estimation of iron stores, and a level of more than 30 is considered normal. And when it's less than 15, it indicates depletion and actually absent iron stores. And you need to understand about hepcidin also now in the situation of COVID, because it is when there is inflammation, there will be an increase in hepcidin, and hepcidin will prevent the iron being absorbed from the intestine because it's the iron regulatory hormone which is being produced by the liver. Hepcidin will have an action on ferroportin, which is actually a cell membrane exporter, and that will help in the absorption of iron from the intestine and transferring to transferrin. So when hepcidin blocks the ferroportin, what will happen is the iron absorption gets reduced and the person goes for anemia, even though they have a dietary iron which is enough for that time of period. So obese women also will have a tendency to have an increased hepcidin, and that's why they become more anemic. And how do you correct iron deficiency anemia? There are multiple strategies, and that can vary from dietary advice to blood transfusions. But the choice which you take will be influenced by the severity of the anemia which you see in the patient, as well as the comorbidities of the patient. So the dietary source of iron are heme iron and non-heme iron, and heme iron is present in liver, red meat, seafood, and poultry, and non-heme iron is seen in beans, dark green leafy vegetables, dried fruit, raisins, and apricots, iron fortified bread, cereal, and pastas. So how do you treat iron deficiency anemia? We're talking about the non-anemic lady where you give a single tablet ferrous sulfate, but for a person who has gone into iron deficiency anemia, you will need to give her 3 tablets per day, and that should provide an elemental iron of almost 100 to 200 milligram every day. But there are studies which say that even if you give 3 tablets, the absorption may not be enough, and she may actually lose it in the intestinal secretions. So most can actually absorb only 2 tablets daily, because when you increase the number of tablets, the dyspepsia and nausea becomes more common. And for nausea and epigastric discomfort, you may need to give preparations which have a lower iron content, which may not correct her anemia also. And when you give slow release and entry-coated forms, the chance of anemia, nausea is actually more common. So when you have a person with epigastric discomfort and nausea, it's better to avoid slow release formulations as well as entry-coated formulations. So there are various studies which tells us that if you give more doses of iron, it's actually not useful at all. So when you give a supplement more than 60 milligram of iron, it will actually increase the hepcidin level, and that will last for almost 24 hours. So what will happen is the next tablet which you give will not even be absorbed. So it will be associated with the lower iron absorption in the following day also, because of the hepcidin rise when you give more of iron supplements. So actually the absorption in iron deficiency is highest at low iron doses of around 40 to 80 milligram. And when you give consecutive days dosing, it will actually result in a decreased iron bioavailability, and you're defeating the purpose of what you started with. So less is actually probably more for treatment of iron deficiency anemia, because when you have a twice daily iron supplementation, it does not have a additional effect when it's compared to the once daily administration. So there's no point in increasing the number of doses when she's more anemic. You may need to go for alternate methods of management at that point of time. And low dose iron given on alternate days is supposed to be the best method to maximize the fractional iron absorption, increase the dose efficacy, reduce the GI exposure to unabsorbed iron, and ultimately improve the tolerance of iron supplements. So giving low dose iron on alternate days may actually prove more of benefit compared to giving her more and more tablets every day. So how do you assess the response to the therapy when you're starting with oral iron? You may need to check her hemoglobin 2 weeks after you started oral iron. And when there's an increment of 1 gram, it tells you that there's a positive result. But suppose you want to check very early, even before 2 weeks have gone, you can do a retic count around 4 to 7 days after you've started oral iron. And if it's increasing, it means she's having a good compliance and the absorption is also good. But if you have no response to the oral iron you started in the form of a rise in hemoglobin or a retic count, it means it's either poor compliance or a poor absorption. So the therapy duration when you start oral iron, ideally it should be 300 milligram, but as I said, all may not be absorbed, and you need to provide for the iron stores. So you need to give a sustained treatment for almost 6 to 12 months of oral therapy to a person who's become anemic. So how do you take? The patient has to be counseled how to take the oral iron supplements, and that needs to be taken on an empty stomach 1 hour before meals with a source of vitamin C, that is ascorbic acid, in a form of orange juice to maximize the absorption. And the patient is not supposed to take any other medications or antacids at the same time. So when do you switch over to parenteral iron is, it is actually better if you give it in the second and third trimesters, because we do not know the safety profile of parenteral iron in the first trimester. So you give it in symptomatic anemia, moderate to severe anemia of 8 to 10 milligram per DL, or when there's insufficient time for oral repletion, which can happen when you confirm that she's anemic at 30 weeks of gestation, then we need to give IV iron. And when the person is becoming intolerant to oral iron, we may need to switch over to parenteral iron. And there's also a specific population which may need parenteral iron even at the first sitting, like a person who's having celiac disease, irritable bowel disease, gastric bypass surgery, a GI malabsorption syndrome, or she's suffering from hyperemesis and she's also anemic. So how do you calculate the dose of iron when you give parenteral iron? It has to be a body weight in kilogram into 2.3 into the expected hemoglobin minus the patient's hemoglobin. And after you get the dose which you need to give, please add 500 milligram for the stores also. So iron sucrose is the one which you use very often now, and it's given as 200 milligram and 100 ml normal saline over 30 minutes. And usually it's given in alternate days to increase absorption, and maximum per days you cannot cross 200 milligram when you give iron sucrose. And how do you check for the response? After you've given 1000 milligram of elemental iron, it will raise the hemoglobin by 1.6 milligram per DL in the next 10 days. And another 0.8 will be added with the 1000 milligram which you've already given, and that will be seen 2 weeks later. And it will also increase the ferritin level, indicating that the stores also will get replenished when you give parenteral iron. And it will actually increase the ferritin level from 2.9 to 122.8, according to a study by Halleck et al. So iron sucrose is actually superior to iron dextran, which was given earlier, and it's got a better safety profile, but its use is limited by the total dose that can be given in one infusion, and the patient will require multiple infusions. And when she's going to come during COVID period for multiple infusions, it's actually going to cause more problems for her. So you can give iron ferric hydroxide carbohydrate complex, that is FCM, which can be given as a single dose of 500 to 1000 milligram over 15 minutes. And the dose should not actually exceed 1000 milligram per week. And it will give a controlled delivery of the iron to the reticuloenteral system for primarily the bone marrow, and it will subsequently be delivered to both ferritin and transferrin. It needs to be diluted only in sterile 0.9% saline. And animal studies have shown that it can be rapidly eliminated from the plasma once it's given, and it will not cause a risk of the ionic iron remaining in the plasma and causing risk to the patient. There's a minimal risk when you give FCM complex. So do you prefer iron sucrose or FCM? The rise in hemoglobin is more and it's earlier with FCM. And it's very important when you're treating a pregnant patient with moderate or severe anemia, especially in the third trimester. And that's an Indian study telling us that it's much better than iron sucrose. So the advantages of FCM is it's a safe IV agent in pregnancy. It is non-inferior to the iron sucrose complex for the treatment. It will actually help in giving the patient a shorter duration of therapy. It's a patient-friendly dosing. It will cause an earlier rise in hemoglobin level and will contribute to a better patient compliance. But you need to know about the precautions which you need to take during a parenteral iron therapy. You need to ensure that cardiopulmonary resuscitation equipment is always available in your center when you're treating patients with parenteral iron. And you need to monitor the patients during and after for 30 minutes after administration, because there's a risk of life-threatening hypersensitivity reactions in a small group of patients. And it's approved for only IV administration. Do not give IM injections. And if there's extravasation, you may need to flush it with 0.9% saline to prevent that extravasation and leakage. And there are some studies which says it reduces the serum phosphate concentrations and can cause hypophosphatemia. It's been consistently reported in many trials, but the thing is they're all transient and asymptomatic, and the overall clinical implications are not known at this point of time. And in some trials of when FCM was used, they've reported hypertensive events during the administration of FCM, but the implications are not known. But if you're going to give a PIH patient with FCM, please monitor hypertension, her blood pressures, because it may shoot up during the therapy. So compared to oral iron, IV iron scores much better because it will cause an additional increase of almost 4.4 grams compared to oral iron, and it will be there for a longer period of time, and we see almost an increase of 7.5 at the time of delivery. So the next point is on postpartum anemia, where you may need to give iron. And please remember, failure to treat maternal iron deficiency anemia will carry over to the next pregnancy. And that's why treating anemic patients, even in the postpartum, is very, very important to prevent the burden of anemia in our country. So this is an algorithm to tell like how they treat anemia in pregnancy. It's a very good study by the Journal of the American College of Hematology. So when you see a pregnant patient with a hemoglobin which is normal, 11 grams, you give a supplementation, but if you diagnose iron deficiency anemia, they do always a ferritin level, because there are other causes of microcytic hypochromic anemia, and that's why estimating ferritin in certain group of patients is very important. And if it's less than 30, it means it's iron deficiency. If the patient is diagnosed in the first trimester, give her an oral iron, which will give a proper amount of elemental iron for 2 weeks, and then check her hemoglobin. If it's increasing by more than 1 gram, you continue that oral iron, and then after she delivers, you check it 6 weeks later, because postpartum anemia, even in supplemented patients, have been seen in almost 14%. So you always check for postpartum period at almost 6 weeks after she delivers. And when you give oral iron and she's not responding, then the pregnancy is around less than 13 weeks. You may need to give either a parenteral iron if she's in the second trimester, or even if it's very low, you may even need to go for a Paxil transfusion to help the baby grow. And if the gestation is more than 13 weeks and the HB has not improved with oral iron, you will continue on to intravenous iron, which will help her much better. If the person is in the second trimester with iron deficiency anemia, and the definition of iron deficiency anemia in second trimester is less than 10.5, for the first trimester it's around 11. So if she's less than 10.5 in the second trimester, you can give her a shot of oral iron. Response is there, you can continue that. No response, you will go on to parenteral iron. But at the first time itself, which is less than 10.5, it's better if you go for intravenous iron and check her count 6 weeks postpartum. And diagnosis of anemia in the third trimester, it's better if you do not experiment with oral iron. It's better if you go for intravenous iron straight away and then manage her throughout the pregnancy. And suppose the ferritin is more than 30 and the anemia is microcytic hypochromic, you will need to do a ferritin to check out for the other cause of anemia, microcytic hypochromic anemia like thalassemia, which is quite common in many parts of the country. So the take-home messages for my talk will be: iron supplementation will be needed in all pregnancies. If she is non-anemic, you would still give her oral iron, supplement her, and repeat her HB and ferritin after 8 weeks of therapy to confirm a response. A low dose alternate day dosing may be considered to improve compliance and increase the absorption. For an anemic patient, when you're correcting her, you need to check her hemoglobin after 2 weeks. For a non-anemic woman, it will be 8 weeks, but for that will be 2 months. But if she's anemic, you need to check her after 2 weeks to find out how she's responding, to assess the compliance, correct the administration, to find out the response to treatment. And parenteral iron is much superior to oral iron for rapid correction of anemia. And once the hemoglobin concentration is the normal range, please remember to replace her for at least 3 months and at least 6 weeks postpartums to replenish the iron store, so that she not come anemic with her for her next pregnancy. I'd like to thank Dr. Jaideep Tank, the O&S team who are doing O2S team, which is doing so well as Dr. Priyankur Roy for the opportunity. Thank you so much.
Thank you so much, ma'am. That was indeed a wonderful talk. Very crisp, and you exactly finished on time with very good take-home messages. So thank you so much, ma'am, for that. We will take up a few questions before we move on to the panel discussion. So yeah, Jaideep sir. Yeah. So sir, there is a question first of all for you from Dr. Maninder Ahuja ma'am. She asks, do we have facility for scalp pH testing in fetuses?
Well, it's actually not a very expensive machine to get. The problem is that the utility of that machine is limited, if you ask me. Because even testing fetal scalp pH does not always augment decision making. Theoretically, it sounds very nice that there is an abnormal fetal heart rate, and then you want to decide whether you want to wait or not. So you estimate fetal pH by doing a fetal blood sample. But in practice, it doesn't really work that way, because the correlation between abnormal CTG and the fetal blood sample becoming acidotic is quite undefined. So if just now the CTG is abnormal, after how much time will the fetus become acidotic? And whether it's medico-legally prudent to wait after the CTG becomes abnormal is anybody's guess. So, for example, we have not invested in a fetal blood sampling machine, and I don't really know too many people in this country who actually have invested in a fetal blood sampling machine. I would actually hesitate before I recommend that you go ahead and purchase it. So theoretically, it sounds very attractive, but in practice, really speaking, I'm afraid it's not really as linear a thought process practically as we think it is.
Thank you, sir. So there's another question from Dr. Padmavati Naidu, ma'am, from Visakhapatnam, and she asks that most of the deliveries happen in the government hospitals and primary health centers where there are no facilities for CTG monitoring. So what should be done?
Okay, so that's why I brought up the issue of intermittent auscultation vis-a-vis fetal monitoring. Hi, Dr. Padmavati, how are you? Pleasure meeting you in Vizag just now. That's why I brought up the issue of intermittent auscultation vis-a-vis electronic fetal monitoring. And the fact of the matter is that if intermittent auscultation is done rigorously, you are going to achieve the same outcome as you would with electronic fetal monitoring. So an intermittent auscultation done correctly is in no way inferior to electronic fetal heart monitoring.
Thank you, sir. So another question from Dr. Rambabu from Visakhapatnam. He asks, what is your opinion on making mean decision delivery interval for grading a maternity hospital?
Well, again, thank you for that question. I think it's an important question because we are now concentrating on quality of care. And I think what you're essentially asking is if decision to delivery time can be made an index of quality, which again sounds very attractive in practice, but doesn't take into account the very diverse settings that we have in our country. We have sometimes entire area, entire village, entire sub-district where there are only 2 or 3 anesthetists, and they are running around from one place to another trying to fulfill all the requirements for anesthesia, and making this as an index of or grading the hospital vis-a-vis insurance payouts or vis-a-vis compensatory packages is really I think not fair to these hospitals who are otherwise providing yeoman's service to the people who are really needing it at the grassroots level. So again, one of those things which sounds excellent in theory, but has a lot of issues which need to be discussed about because of the diversity of settings that we have in our country.
So Dr. Rekha from Yavatmal asks, does oxygen supplementation to mother reduce intrapartum fetal distress? Is there any evidence for it?
No, absolutely not. In fact, I said it, the recent Cochrane review seems to suggest that not only does it not help, it could actually do some harm by actually, giving a false kind of a reassurance and delaying action.
Thank you, sir. There are a lot of congratulatory messages. And Dr. Yashodhara Pradeep ma'am from Nellore and Dr. Lakshmi Shikande ma'am from both of them have sent congratulatory messages and also have wished you all the best for your presidential election next year, and they wish to see you as the FOGSI president next year, sir. Continuation of a lot of activities. So thank you, sir. And now we have a few questions for Charmila ma'am. So ma'am, the first of the questions is from Dr. Kiran from Kanpur, Dr. Kiran Sinha ma'am. She asks, FCM doses can be repeated? If yes, after how many weeks?
FCM giving is actually they are saying 1000 milligram, but you should not exceed 500 milligram, because when you have too much of iron overload, that's also going to cause problem during pregnancy. And there are very few trials which tells you the safety of parental iron beyond a point. For a country like us, when you need to have compliance, we are moved ahead with FCM, but do not repeat again and again, because if she's not going to respond, suppose you give 500 milligram iron today, repeat it after a week and give the total dose of 1000 milligram. Do not give like a non-pregnant patient 1000 milligram at a single shot. And once you're given that and see for the response after 2 weeks, she's not responding, it means that it's not iron deficiency, because you're given the parental iron, which is the ideal dose, and still she's not responding. Rule out the other causes of microcytic hypochromic anemia. Do a full workup of her iron stores, and first you do a ferritin level to find out how the stores are. Because if the stores are high, it's going to be some other form of iron. And that's why I put up the last slide, but I didn't explain because I didn't have time. Because when you load, it's going to cause hemochromatosis, and that's also going to cause lots of problem to the mother. So always check ferritin level. If she's not responding to your parental dose, which you've calculated correctly and given, and no response, check and then treat her. Do not keep on giving FCM just because it's available with you.
Ma'am, Dr. Uma Devi ma'am from Hyderabad asked whether FCM is already an approved drug or is it still in the experimental phase?
No, it's approved now. It's approved at this point of time. And iron sucrose, so government of India is talking about iron sucrose, the Mukt Bharat, the campaign, but FCM is now approved for use for pregnancy. But do not give it in the first trimester because there are not much of studies. But if the person is very anemic and you do not want to give a transfusion, even in the first trimester, given with a proper counseling of the patient.
Ma'am, Dr. Rambabu from Visakhapatnam asks, does supplying vitamin C along with iron and folic acid during antenatal program, is it helpful and
Yes.
or economical, and should it be given?
It's helpful, but most of the formulations will have some amount of vitamin C. You check the formulation and then give to the patient. When you give a combination of folic acid, cobalamin, iron along with vitamin C, that will be the best combination, because then going and checking whether she's megaloblastic and then correcting her folic acid and all that does not make sense when our patients do not come correctly for checkups. So give everything at the same time, and there are combinations which are not costly also with all these there.
Thank you, ma'am. And just the last question before we move on to the panel discussion. Question from Dr. Indira from Vizag. She asks, do we need to do ferritin levels in all cases of anemia routinely?
Not routinely, because it's a costly investigation, but when needed, do not avoid doing it, because you may actually save the patient sometimes, because you will have some other form of anemia and you will just be giving iron again and again, and it will cause its own problems. So do not overload her. When it's needed, it needs to be given. And that's what I said. Please have an algorithm for all your patients. If she is not anemic, check her hemoglobin after 8 weeks to see how much she is. Suppose she is anemic, check after 2 weeks to see how she has responded. She's not responding to oral iron, continue parental iron. But when you're going for parental iron, it's worthwhile doing a ferritin and then going for a parental iron, because you may think that she's not compliant or not absorbing or something like that, but it may be some other form of anemia. And in certain populations like the Northeast and some pockets in South India, we have got thalassemia patients. So you need to rule out that before you keep on overloading her with iron, which may be harmful, because iron, when it's in the circulation, that's also going to cause harm to the fetus as well as the mother.
Thank you so very much, ma'am. A lot of congratulatory messages for you too. So
Thank you, Priyanka. Thank you, Priyanka.
So no academic program happens without academic partners. And today, Torrent is our academic partner, and they have a small video to show all of us. So Saurav, requesting you to kindly start the video.
The triangle of B complex is essential for pregnant women in their dietary process, as while conceiving, women find it difficult to produce adequate levels of vitamins. With external supplements, they get their required dosage, which is ready for absorption and utility by the body. Vitamin D also is most crucial in pregnancy and lactation. For prevention from adverse outcomes, future risk to health of child, and maternal and fetal health during pregnancy. European Society for Pediatric Endocrinology confirms vitamin D3 2000 IU per day ensures adequate vitamin D status in pregnancy and early infancy. Vitamin D3 supplementation helps achieve the sufficiency and can be taken for a long duration. Calcium also plays an important role in pregnancy as its twofold requirement increases. Adequate maternal health is needed for fetal bone health, and as per the BMC Public Health article, calcium supplementation during pregnancy reduces gestational hypertension by 45% and preeclampsia by 59%. Effective management of pregnancy demands supplementation of prenatal vitamins. This supplementation provides protection against various defects that can occur during pregnancy. Shellcal XT provides protection against neural tube defects. It reduces the risk of preterm birth and congenital heart diseases. Shellcal XT contains 1250 mg of calcium carbonate, which is required to maintain maternal skeletal calcium. 2000 IU of vitamin D ensures adequate status in pregnancy and early infancy. Shellcal XT has 1000 micrograms of L-methylfolate. Journal of Clinical Pharmacology and New Drugs confirms that L-methylfolate helps in decreasing the risk of NTD by 72%. The methylcobalamin at 1500 micrograms improves pregnancy outcome and maintains normal folate metabolism. The additional pyridoxal 5-phosphate at 20 mg reduces nausea and vomiting in pregnant women. From preconception, pregnancy to lactation, Shellcal XT is a world-class product for vitamin supplementation. Shellcal XT has special coating technology and vitamin D3 in stabilized form. Shellcal XT helps to reduce the pill burden. Dosage of Shellcal XT is 1 tablet once a day. Each ingredient in Shellcal XT is coated separately, so there is no drug-to-drug interaction. Shellcal XT scored tablet gives dosage convenience. A healthy start leads to healthy mothers, and healthy mothers make a healthy generation. After all, every pregnancy is precious.
Thank you. Thank you, Saurav. Now we move to the much awaited panel discussion. So to moderate this panel, we have Dr. Ashok Kumar sir. Sir is the Director, Professor and Head, Department of OBGYN at the Atal Bihari Vajpayee Institute of Medical Sciences and RMLH Hospital in New Delhi. He is the Secretary-elect of the ICOG 2021-22 and is an editorial board member of a number of journals and published a number of papers in various national and international journals. So I hand over this session to Ashok Kumar sir for self-introduction of all the panelists, and then we move on with the panel discussion on fever in pregnancy. I'm also happy to inform all of you that we have 5,400 delegates who are watching us right now. And I'm also happy to inform that in spite of being a new year, we have all the 7 esteemed panelists with us today. So it's a matter of pleasure for us that all of you are participating and we'll have great inputs in today's program. So thank you, and over to you, Ashok sir.
Good evening, everyone. Am I audible?
Yes, sir, you are.
Okay. Good evening. First of all, thanks to this O2S series for inviting us to this panel in fever in pregnancy. So I request the host to keep everyone on the screen, and we start the panel discussion. First, let me ask everyone to introduce one by one themselves for the audience. So we start with Dr. Girish. Please introduce yourself.
Yeah, myself, Dr. Girish Mane. I am chairperson of Adolescent Health Committee FOXI 1921, and I am from Yavatmal.
May I request Dr. Kalyan sir to...
Good evening. I am Dr. Kalyan Barmade from Latur. I am chairperson of Public Awareness Committee of FOXI. Thank you so much.
Good evening. Can we request Dr. Radha to please introduce?
Yeah, good evening, everyone. I'm Dr. Radha from Visakhapatnam. I'm president of OG Society of Visakhapatnam.
Okay. Thank you, madam. Can Jayashree Gajaraj to introduce?
Good evening. I'm Dr. Jayashree Gajaraj from Chennai.
Good evening. We have next is Dr. Asha Bakshi. I think she doesn't need any introduction. Madam, please.
Good evening. I'm Dr. Asha Bakshi from Indore, and I'm Vice President-elect for the year 2023.
Thank you, madam. Next, we have Dr. Anju Soni, madam. Again, she doesn't need any introduction. Still, we have 40 to do.
Anju, you're mute.
You are not audible, madam.
Anju, unmute.
No, I'm not muted.
Now we can hear you, ma'am.
Yeah.
Yeah. Good evening. Thanks, Dr. Ashok. I am Dr. Anju Soni, Chairperson HIV and AIDS, and elect for Indian Menopause Society, Secretary General elect, 2022.
Next, we have Dr. Aruna Kumari. Madam, please.
Good evening, everybody. I'm Dr. Aruna from Rajahmundry, a consultant gynecologist.
Okay.
Thank you.
So, welcome all panelists and esteemed faculty. We start the panel discussion. We try to complete some topic in fever in pregnancy because it is a very vast topic, but cover as many as possible during the time allotted to us. Yes, yes, madam.
Sir, your bandwidth is very low. If you stop your video, maybe your voice
Okay.
clear.
I will try to change my connection. Let's see if it improves. Probably, yes. Good evening. Now, probably it will improve. Let's see. If still there is disturbance, then I will try to do something more. Am I audible now? Yes?
Yeah.
Yeah. Yes. So, as I was saying that this fever in pregnancy is a very vast topic and it has a lot of topics, subtopics to be discussed in this, but we try to see what all we can cover during the allotted time. And let's start with the Dr. Radha. Can you tell us a differential diagnosis of fever in pregnancy?
Thank you, Dr. Ashok Kumar. I would consider differential diagnosis of fever in two categories, non-obstetric and obstetric. You know, non-obstetric is mostly of infectious origin. And for example, any febrile illness irrespective of gestational age, now we consider COVID first and then go to the other infections. And other common infections apart from COVID can be like viral infections can be seasonal flu or H1N1 or vector-borne infections like dengue, or uncommon but problematic infections like varicella zoster or chickenpox, and endemic parasitic infections like malaria. And then if you go to bacterial infections, the urinary tract infections, either upper or lower tract infections, and bacterial pneumonia, typhoid or GI infections, or acute febrile illness with tuberculosis. And we have to consider other surgical causes like appendicitis also. I'm not mentioning the other deceptively unnoticed transient illnesses or viral infections which can cause morbidity in the mother or offspring like other infections or hepatitis and other infections. And also the other endemic to other continents like Zika or Lassa fever, which are equally problematic. And coming to the obstetric causes of fever, they are depending on the various gestational ages. It can be a septic abortion or a post-abortal sepsis or interpartum fever and intraamniotic infections and postpartum endometritis. And when we come to the postpartum fever, other non-infectious or other obstetric related but not actually pelvic sepsis, it can be mastitis or aspiration pneumonia, or a fever resultant to neuraxial anesthesia, or either surgical site infections or drug fevers, or all those have to be considered.
Yeah. Thank you, Dr. Radha. As you correctly said that there's so many causes, and especially the postpartum period also one has to consider. And being an obstetrician, we should always keep in mind that there are non-obstetrical causes, and one has to really consider the local causes. It might be malaria, or it might be endemic area, or sometime in that season typhoid is more prevalent, or dengue, or some chikungunya, something like that. So one has to keep all these things in mind. We should not restrict ourselves to the obstetric causes. So once we know these are different causes of fever in pregnancy, but
if you don't mind, can I add something?
Yes, please. Yeah.
Actually, fever is not a disease. It is a sign as well as it is a symptom. And there are some other, causes also. For example, the physiological fever. For example, if sometimes if the patient is malnourished, or if the patient is dehydrated, even there is sometimes diurnal variation of the fever also. So we should not forget the physiological increase in the temperature of the body also, probably.
Yeah, or certain drugs like atropine, they also cause because heat loss they prevent because of the sympathetic or parasympathetic block. Then they can also cause fever.
Yes, madam. No, that's all right. Yes, Dr. Girish has correctly highlighted about the physiological one and some drug causes also. Yes, we should not forget this. Now, because fever is a symptom actually, and that is why I started with different causes of what could be the possibility. Because once you take the history and you try to examine the patient, you try to localize some time that, and with those you can sometimes localize the cause of fever, that probably this might be the cause of fever, but sometimes we never able to localize the cause of the fever. Then comes the confusion that what to do and why the fever is having this patient. So before we proceed to the individual problems or the individual diseases, I request Dr. Jayashree, can you please tell us what are the adverse effects of fever per se? See, if any patient is having fever, like fever can be a problematic, can harm to the pregnancy. What are these issues?
Yeah. Thank you, Dr. Ashok. I think fever per se is a very, very common sign or symptom. And when to make that realization that it is significant and we need to investigate, we need to treat, is a very, very difficult step, because sometimes we keep treating 1 day, 2 days, we think it's a common flu, but actually it is something else. And that is when we as obstetricians or healthcare givers make a mistake, because we are not recognizing in time what the possible cause can be. So it is very important, and it is actually, the adverse effects can vary, anything from maternal sepsis itself causing problems to miscarriages, preterm birth, chorioamnionitis, and depending on what gestational age the fever or the presumed infection occurs, the possibility of even congenital malformations is quite high. So it is not so much the fever itself that may affect as the cause of the fever, which may actually cause the problems. So it's the inflammatory reaction to whatever the causative agent is, what it is. That is the reason why we have these problems. And immediately, as soon as there is fever and a possible infection, we are talking of the need for antibiotics. What is the effect of antibiotics on the pregnancy, the mom and the baby? The need for hospitalization sometimes, which can actually increase the morbidity, and even today, sad to say, mortality is still there. So these are all the different effects that fever can have. And one way of looking at it is a persistent temperature of more than 38 degrees Celsius maybe is some kind of an indication for us that we need to have our alert signals up. So it can affect the mother, the baby, the pregnancy in many, many ways. And it's as high as 22%.
Yes. Beside this, yes, one should not forget it. Isolated like fever, when we don't have a visible cause and when we are investigated, we have to keep the fever down, because it may lead to, again, dehydration or other discomfort to the patient. And as you rightly told, that miscarriages might be a problem when there is a high degree of fever. So now, when we know these type of, yes, please.
Even sudden IUDs are very common with a high grade.
With high fever, yes.
And meconium lacquer is also common.
Meconium staining also. Yeah.
And preterm labor.
So preterm patient go in preterm labor also.
Yeah.
So these are the problems. So we should not ignore fever in pregnancy. So that is the message from this discussion I wanted to highlight. So now, before further going to the details of each common problems in fever in pregnancy, see, as Dr. Jayashree has also told, that antibiotic is the now come into picture. So just we want to highlight where we will use antibiotic and where we want to avoid antibiotic. So can I request Dr. Asha about antibiotic role, or whether you want to give antibiotic for just a single dose or for 7 days in cesarean section?
Right. Ideally, the things should be such that there should be no role of antibiotic in cesarean section. But then studies have suggested that it is a very good idea to give prophylactic antibiotic to prevent the maternal morbidity and mortality. And usually it is suggested that 1 hour before the incision, the antibiotic should be given. Or if you have already, there is an emergency and you don't have time, then try to give it as soon as possible. And the antibiotic that you use for surgical prophylaxis should be a very simple antibiotic. And mostly the recommended antibiotic is first generation cephalosporin, and that is cephalosporin. And the dose is 1 gram if the weight is less than 80 kilo. And if it is more than 80 kilo, then 2 grams. And if somebody is allergic to cephalosporin, then one can go for Dalacin, clindamycin, which can also be given as 900 milligram, or some aminoglycoside. And if someone is really obese, then again here you have to increase the dose. And if someone is having the procedure has gone for a long time, say for more than 2-3 hours, then you may have to repeat the dose of the antibiotic. And another thing is sometimes in obese women, you may want to continue the antibiotic for some time, at least for 48 hours. So these are the patients. If someone has got preterm premature rupture of membranes, then these are again patients for whom you have to give antibiotic for at least 7 days. And especially if a patient is in labor and you are planning to do her cesarean, then there is one interesting thing that you can do vaginal cleansing of these patients with betadine. And even if someone has got preterm premature rupture, premature rupture of membranes, and you are going to do a cesarean, then here also they have recommended use of vaginal cleansing. So this is, so whatever it is, I try to be simple, use simple antibiotics rather than complicated antibiotics. Let us leave the higher antibiotics for further complications, because what happens if you use, then there is a chance of antibiotic resistance and the organism comes with more virulence. So I think let's be simple and save the globe from all these complications.
Can I add?
Madam, just
current recommendation is to add azithromycin 500 milligrams also to, along with cefazolin.
Yeah, if it is a prolonged obesity.
Yeah. So prophylactic antibiotic for cesarean, when we are planning cesarean, that is one thing. Second is, if we feel there is a high risk of infection, like chorioamnitis or multiple PV examination or prolonged labor or something like that, or prolonged rupture of membrane. So in those situations, we expect that we will continue antibiotic for a prolonged period. But fact is that we have seen in many places, antibiotics is given for a longer time also, maybe up to 7 days or maybe up to the time of stitch removal. So those variations are there from different places or from different obstetrician. So any comments from my panelists on that?
I don't think it should be done. Surgical prophylaxis is good enough, and there is no need for long term. Only in some cases where you are suspecting some infection or some fever is there, then you can give for long-term 7
Dr.
days.
Jayashree, please.
Yeah, I think in those situations, it's no longer prophylactic. It becomes a treatment.
Yeah, exactly.
And I have followed this for almost 35 years now, and I've never had an issue. Even in diabetics, sometimes my registrars will ask me, ma'am, but she's a diabetic. There is no need to deviate from prophylactic antibiotics. And one recommendation is that every unit should have their own policy, because it's not a uniform, like one antibiotic can be used across the globe. What is the prevalence of infection in our own unit, in our own city? And then you have a antibiotic policy which you have to follow and review and change from time to time, depending on the infection control group, which will give you guidance on that. So I would strongly recommend prophylactic antibiotics for all cases.
And then there is a practice to add metronidazole to every regimen, antibiotic regimen. That is also
not to all. Only where there is means if the woman is obese or if the procedure is long.
So there is a lot of variation. Any other panelists want to comment on this, or we continue further?
I agree. Every hospital should have their own policy, antibiotic policy as per the guidelines, and then give that antibiotic. And if we give antibiotics, more antibiotics, we are going to create problem for ourselves only, not for patient, for ourselves. So restricting the use of antibiotics is very, very important. And this message should go clear to everyone that we should give only prophylactic antibiotics and no role of adding any, antibiotic like Metrogyl and all. I don't prefer giving Metrogyl in my patients. And because it has not only give you bad taste, nausea and all other problems, it doesn't give us any kind of benefit except in some conditions, maybe premature rupture of membranes or prolonged labor, etc.
Sir, theoretically, metronidazole should always be given after clamping of the umbilical cord, I guess.
Yeah, that is another view on the administration of metronidazole. Yes, some people recommend this type of practice also. Dr. Aruna, you want to add something?
I perfectly agree for this prophylactic antibiotic. That is our schedule also. For those cases where there's a prolonged labor or prolonged rupture of membranes, or those with the evidence of any infection or fever, there we will give treatment. There we will extend the use of antibiotics for either 48 hours or 1 week, depending upon the clinical situation. Otherwise, in clean cases, clean antepartum cases, clean elective cases, only prophylactic is enough.
Okay.
Sir,
and prophylaxis, you give cefazolin or cefazolin with Metrogyl?
Only cefazolin. In some cases of prolonged labor and premature rupture of membranes, postpartum, I'll add metronidazole for 48 hours.
Okay.
Sir, in case it's a prolonged labor or PRO, then the neonate has also to be given antibiotics according to the, as per a neonatologist, they will check for everything and then go ahead.
Probably
Yes,
we are
madam.
not used to use clindamycin so much, so that metronidazole is used for anaerobic infections.
Now, this is very clear about cesarean prophylactic antibiotic, and if there is some complicated issue, one can prolong the antibiotic in the postpartum period also. So that is clear. But about normal vaginal delivery, whether we should give routinely antibiotic or we should not. What is the opinion, Dr. Kalyan? Please.
In normal vaginal deliveries, there is no role of any antibiotics until it's an operative vaginal delivery like vacuum of forceps, where you can give single shot of prophylactic antibiotics. A decision to routinely administer prophylactic antibiotics after operative delivery needs to be balanced by the patient features, where childbirth facility is being done and what is the provider's experience. Like in a PSC where delivery is done in a setup where it is an emergency delivery where facility is not there, then you can give a prophylactic antibiotic. If I am doing in a maternity home, which is a good sterile maternity home and labor room is clean, then there is no role of giving any antibiotic in a normal delivery setup.
So if the patient is coming with some symptom, like for example, she is having fever, or if she's having chills only, or if she's having some other infection, for example, urinary tract infection or respiratory tract infection, or if she is severely anemic, or what as Kalyan has already been quoted, that there are no hygienic facilities, and even if the patient is having query PRM, then probably there is a need of prophylactic antibiotic. But if everything is okay and if you are not suspecting any other thing, then there is no need of any prophylactic antibiotic, because again there are chances of reaction to the antibiotic also. One should not forget about this.
Only good episiotomy care is required, because whenever she is going to a washroom, she should clean the wound, and you can apply betadine ointment at the site of episiotomy 3 to 4 times a day.
Yes,
Sir,
yes, Madam Dr. Anju. Yes,
Sir, I would like to add here that when we talk of vaginal delivery, the importance of partogram is there. Not doing too many pervaginal, unnecessary pervaginal examination, not prolonging the labor. And if any time you feel the labor is being prolonged, you should add antibiotics. Otherwise, there is no need. And proper painting and draping with betadine is again very, very important. Using sterile, drapes for the patient and taking all those precautions are very essential. That will prevent any kind of infection.
So what I understand from the discussion from my panelists is that for uncomplicated vaginal delivery without any complication, and if your setup is clear and you're following all aseptic precaution, then routine administration of antibiotic is not required. However, if you feel some complications are there, if you feel there's some option or some possibility of infection is there at the time of delivery, then you can add antibiotic. Is there any difference of opinion on this?
Correct.
Okay, so if we agree on this, then we come to the next point where antibiotic has an important role, or whether we should give, what precaution we have to take when we administer antibiotic in a case of PPROM, premature or preterm rupture of membranes. In these situations, they are a little bit confusion, as Dr. Anju Soni will highlight that, and she has already told some point. But what are the precaution and which antibiotic to give, madam?
So first of all, we should understand what is premature rupture of membranes. There are two types. Basically, when we talk of PPROM, it is whether it is before 24 weeks or it is after 24 weeks. And if it is before 24 weeks, the management completely varies. 22 weeks rather 24 weeks. And if it is after 24 weeks, again the management varies. So first of thing is when is the PROM happening? Number one. Number two, we need to confirm whether it is actually a premature rupture of membrane or it is not there. And if it is, we need to confirm that by doing putting a sterile speculum in the vagina, not doing a pelvic PV, what we call it.
That's fine. It is a confirmed PPROM. Now how to proceed for antibiotic?
So we need to first monitor the patient. Whether she is having any kind of infection. If it is not, patient is not having any kind of infection, we take the cultures from the vagina and then proceed, monitor the mother as well as the fetus very, very carefully. That is very, very important. You need to monitor mother's pulse, blood pressure, her temperature chart, and also leaking, using a sterile pad and watching her for leak. These are very important. And if you feel that she's got any of the symptoms of any kind of infection, we should put her on antibiotic. Again, when we talk of giving a prophylactic antibiotic, we should give the simpler antibiotics like simple ampicillin or erythromycin or azithromycin. And sometimes if a patient is allergic to ampicillin or this penicillin group, then we can easily give her clindamycin. That's quite safe and good. So these are the things we should do and give her antibiotics accordingly.
Dr. Radha, would you like to? Yes, madam, please continue here. Dr. Anju, madam, please. Yeah,
if we have to continue, and then again, it again depends on the infection time. Supposing the patient is having the leak cures, so patient can be managed in OPD. Then we can call the mother accordingly and monitor her, looking at her NSTs and weekly NST and doing a fetal Doppler and also ultrasound to see about the lichen and other things.
Yes, madam. Dr. Radha, you want to add something? Yeah.
I agree to some extent. Suppose it's a preterm PROM and we are continuing the pregnancy. But suppose we are thinking of intrapartum or early rupture of membranes, or nearer term, and then there is a PROM. There is a 20 to 25% of PROM not treated with the antibiotics may end up in intraamniotic infections. So, and the duration of PROM in labor, that also in the before labor also.
Madam, we are just restricting ourselves to the PPROM. PROM, we are not concerned. We are talking about PPROM.
Another important point is
because with PPROM, that is one situation. The other is during PPROM, after PPROM, she developed features of chorioamnitis.
Continuing pregnancy or terminating pregnancy.
No, we are continuing pregnancy. So if we are continuing pregnancy, so that is what we wanted to have the opinion of the panelists, which one and what to do when these type of situation occur in respect to the antibiotics. Other management.
Can I add? Before starting any antibiotic, I think one should do high vaginal swab also, one for routine and as well as for GBS. And then you can start the antibiotic. And once she's settled, then you can, after 7 days or so.
What is your choice, madam? Which antibiotic you want to give?
Erythromycin. Usually I start with erythromycin.
Erythromycin.
Sir,
yes, please.
The first stage, confirmation of PPRM. The stage number 2, if it is PPRM confirmed, you have to start antibiotic at any cost. That is my personal opinion. I'm always giving injection ceftriaxone, then take the swab, send it to the lab, get the culture sensitivity done, and then the specific antibiotic should be started. And if there is no infection, then we can continue the pregnancy. But if at all there are the infection, then in most of the cases, the higher antibiotics, whichever are the applicable in that cases, they should be continued. Yeah.
Yes. You want to add something?
Ceftriaxone is high antibiotic to be started. I will not agree with you.
Pardon?
We have to start with the simpler antibiotics.
No,
the broad spectrum antibiotics should be given.
When patient have features of choriomyelitis, then one should shift to higher antibiotics.
Yeah, of course.
Yes.
Culture sensitive.
Yes.
Aruna, please. Madam, otherwise the consequences will be very bad. If she develops the choriomyelitis, the consequences will be very bad rather than the effect of those antibiotics.
So, Dr. Aruna Kumari, please.
As Dr. Kalyan said, first we should confirm PPR1, then we should decide whether we are giving conservative management or terminating the patient. To decision, we should have take some points: the maternal age, the fetal status, the infection. If there is already infection, we should terminate the patient. If there is no evidence of infection, then we should give prophylactic antibiotic for 1 week.
Madam, if the report is giving presence of Escherichia coli, then what will you do? This is an infection.
Is it contamination or infection?
No.
If it is chorioamnionitis, better to terminate.
Available data.
No, there are two things which I wanted to highlight here.
Yeah, even in postpartum dermatitis or the intraamniotic infection, there is no need for culture, and it may lead to the report of contamination. So they better to start a broad spectrum antibiotic if you want to start antibiotic. Otherwise, if you are continuing pregnancy, stop with a short dose of antibiotic and continue pregnancy. So if you are
viable
intraamniotic infection, by this there is one III signs. There is a suspected or confirmed there is an intraamniotic infection. There is a III criteria to say whether there is an intraamniotic infection or not. So basing on that,
Madam, there are 2-3 things which is very clear with the PPROM. One is diagnosis is confirmed. Second, we wanted to do conservative management. Now we have to send the culture also. That up till this point, I think there is no confusion and everyone agrees on that. But the culture report will take some time, and once the report comes, as per the sensitivity pattern, one can give the antibiotic. That is a different thing.
Yes.
But here we are talking of giving antibiotic before a report comes and patient has covered PPRM and we are doing conservative management. So the different guidelines, international guidelines have different take on that. And they say azithromycin followed by erythromycin, or they say high dose of ampicillin, they say even 2 gram ampicillin IV 6 hourly you give for 24 hours, then you switch over to erythromycin. Some people say that you add gentamicin also, or to take care of gram negative, and you give metronidazole to take care of this anaerobe infection also for 24 hours, then you can switch over to oral antibiotics. So they have different options. But the important thing is, yes, we have to give some antibiotic.
Yes.
As per your local protocol. You have to have local protocol, and this it is visible with our discussion that different person from different places have different protocol in these situations. And that is the message which I wanted to highlight, that each institute or each area should have their own protocol for antibiotic. Their antibiotic profile of that area should be available in these situations, and they should prescribe that antibiotic. We should not follow blindly the international guideline. That is number one. Second is, it is very important to realize in this situation that one should not give amoxicillin with the sulfabectam combination. That is being avoided because it may have some adverse side effect on the. So this precaution we have to take. Otherwise, for PPROM, antibiotics is necessity, and one should give as per the institution policy. It's some give for 24 hours injectable, then they switch over to oral antibiotic. But yes, till the time you are continuing the pregnancy, you should give antibiotic. There is no doubt on that. So if everyone agrees up till now, we continue further. Or if still,
Ashok, sir, which antibiotic is given in your institution? Can you please?
Sir, I follow ampicillin high dose with gentamicin and metronidazole injectable for 24 hours. And if patient have no evidence of chorioamnionitis by that time, and we usually when we send the high vaginal swab, usually it comes as a mix or contamination. So we have to continue with this antibiotic. So after 24 to 48 hours, we switch over to oral antibiotic, and which is erythromycin.
Actually, there is gentamicin. Is 5 milligrams per kg for 24.
Yeah, 3 to 5 milligram per kg. Yeah.
So
this is what I follow, but as we have discussed, we have different opinion and different options, and every place have their different practices. So they follow that in view of, and probably we all are getting the equally good outcome with all whatever we are following these antibiotic profile. So after PPROM, the next issue is which I wanted to discuss, and I want Dr. Aruna and other people can also give their input, is that we know, as per the recommendation of Western literature, rheumatic heart disease, when the patient comes in labor or they goes in labor, prophylactic for subacute bacterial endocarditis is being recommended earlier when we used to be the resident or student. But now with this guideline, which has come recently, they say now no antibiotics is required in labor. Only if few indications are there, then you give antibiotics. So what is the opinion of my panelists on that, whether they prefer to give antibiotic in a patient of heart disease who are going to deliver, or we just avoid giving antibiotic? Okay. Yes, Doctor. We start with Dr. Aruna.
Yeah, according to present guidelines, there is no role of antibiotic prophylaxis to prevent infective endocarditis prophylaxis. Why? Because there's no studies which proved the effectiveness of the antibiotics in prevention of infective endocarditis prophylaxis.
Yes. Yes.
And there's the emergence of bacterial resistance, as already Madam told, and the anaphylactic reactions to these drugs. So the American Heart Association reviewed these guidelines in 2007. According to these guidelines, the infective endocarditis prophylaxis is recommended only few conditions where the occurrence of infective endocarditis is associated with very adverse outcomes, like those patients with prosthetic valves, and those patients who had previous attack of infective endocarditis, or those patients who have cyanotic congenital heart diseases, or those patients who have cardiac transplant. These are the conditions where they recommend infective endocarditis prophylaxis. In our situation, already we discussed the antibiotic prophylaxis for cesarean, for normal delivery. I think these prophylactic antibiotics will do with rheumatic heart disease patients also.
Yes. So this is one opinion. Yes. Any difference, Dr. Jayashree? What are you practicing at your center?
See, most of the time, these patients, we are working along with a cardiologist. So we need to also take their opinion into mind, because we may deliver, but
no. As an obstetrician, we want to give antibiotic, or we don't want to give antibiotic?
I would follow all the criteria that Aruna has just pointed out, and I think there are clear indications. But as a routine, there is no need to.
Dr. Asha?
Same what Aruna has spoken, nothing.
Yeah. Okay. So it means we have changed our practice, that now we are restricting the antibiotic use in these patients. So that is a good news, that we are restricting the use. But I think when we all know that we have to keep in mind our local practices and local aseptic situation where we are delivering these women. If we are happy and satisfied with that situation, then probably antibiotic, as per the recommendation, should be followed. Otherwise, for Indian setup, there is a possibility that one may use antibiotic on a liberal note. So I don't know whether that is correct or wrong, but this is being followed, because the point they give in favor that probably the setup where they're delivering these high risk patient of rheumatic heart disease, and they are very high risk for subacute bacterial endocarditis, and which is very high mortality. So if their birth table or delivery place or the delivery room or the ward or wherever they are delivering, it is not very good in terms of asepsis, then probably they would like to give antibiotic. So it has a different take. So again, this is a gray area where every institute or every place should have their own policy on this, and accordingly they can choose the antibiotic they want to give or they don't want to give. I think with that we can continue ahead, or anybody wants to have any comment?
One point alone, if I can add, if FOGSI can give us a recommendation on the international guideline, because medico-legally also we need somebody to fall back on.
Yes, madam. Yes, madam. Yes. Yeah, these are the issues or the problems or the limitation in private practice or the institution where these type of things, one has to be very careful when we prescribe antibiotic. So last situation is Dr. Girish Mane. I would like to simply highlight from you that what type of antibiotic you will prefer in a case of puerperal sepsis. We know puerperal sepsis is a definite diagnosis in the postpartum period. So it is very clear that we will give antibiotic. The problem is different people give different type of antibiotic. So one should understand and what type of antibiotic you will prefer.
Yeah, sir, everyone knows what exactly the puerperal sepsis is. There are many predisposing factors causing the puerperal sepsis, and they should be taken into consideration. For example, when the patient was, or in her antepartum period, whether she was malnutrited, then whether she was anemic, was there preterm delivery, was there early rupture or PROM, or whatever, I mean, whether she's a patient of diabetes or whether she's obese, whether she had a history of HIV, so and so. Then even while doing the delivery or in the intrapartum period, where the examinations were done, was she in dehydration or ketoacidosis, was there any traumatic vaginal delivery, so and so. And the casual organism, everybody knows that they are aerobic and anaerobic. So again, it depends upon the severity of that condition. I mean, whether it is mild, moderate, or severe. And usually we are preferring the this broad spectrum antibiotic before the culture sensitivity report, and the routine antibiotics given in such conditions, they are gentamicin plus clindamycin or metronidazole with penicillin. Initially many people they used to give, then one combination of clindamycin and astrozonam is very good, then ampicillin with gentamicin can be preferred. But nowadays, if the patient is having severe, this puerperal sepsis, then the combination regimes they are preferred in most of the institution. For example, piperacillin with tazobactam, and the newer or the higher antibiotics like carbapenem if the patient is having very high grade of this puerperal sepsis. And there are some patients or the woman with some specific infection, and in such conditions vancomycin or other some higher antibiotics can be used. And in many cases, even the surgical management is also very important. For example, if there is any issue with the stitch or the perineal wound, or there may be need of even surgical evacuation of the pus formation, isn't it? Then sometimes a colpotomy is needed, sometimes the laparotomy is needed, and sometimes even hysterectomy can be even needed if there is like pus inside the uterus.
So yes, so you rightly said that 2-3 things is that it is a polymicrobial infection, gram positive, gram negative, and anaerobes. So one has to choose a broad spectrum antibiotic, and probably single antibiotic will not help. One has to have again polytherapy, means we have to have antibiotic which will cover gram positive, gram negative, and anaerobes also. So as you rightly said, the combination, these are the things which are important, and this is a message which we want to give it to the audience. That's yes, on single antibiotic will not help.
And then one important message that only antibiotic won't work. Many times,
obviously, yes. Yeah. We have to supplement the disease as per the treatment as per the condition of the patient. But for antibiotic, polymicrobial disease, so we have to cover all organisms, gram positive, gram negative, and anaerobes. So for that, you can decide at your level which antibiotic you will prefer in this situation. And obviously, you have to give injectable antibiotic, and maybe probably on a higher dose, because puerperal sepsis is a very, again, with high mortality and morbidity. So now after discussing the role of antibiotic in obstetrics and to take care of some situation with fever in pregnancy, we come to the specific situation. And I think unless we start and we give importance to the COVID-19 or the corona in this time, we will fail to do our duties. So we start with COVID-19 in pregnancy. That is one of the important cause of fever nowadays in pregnancy, in pregnant women. So Dr. Radha, can you tell us if patient has COVID-19, so we are confirming the diagnosis and we have this patient, pregnant patient, what are the risks to the mother or to the fetus?
Yeah, I am afraid it will be a lengthy answer because we have to consider that in three aspects. Number one is what is the effect of pregnancy on COVID, that it is the susceptibility of the women to COVID is not increased. And secondly, 90% of women have mild disease and recover. But having said that, the current statistics shows the pregnant women have a worse disease than the non-pregnant women, because a serious illness or intubation or deaths are more reported in pregnant women than non-pregnant population. So that is the pregnancy on COVID. And then the COVID effect on pregnancy, mostly the data shows that preterm births and cesarean sections are increased. Or sometimes the high fever or illness may cause stillbirths in the baby also. The importance of cesarean section and preterm birth, they may be iatrogenic also, because the obstetrician may choose the option of delivering the baby in anticipation of worsening of the illness of the woman and management difficulties in the woman. So that is the other one. And one chance of increased preeclampsia is also reported in these women affected by COVID. The other aspect we have to discuss is safety of medication and difficulties in the taking care of the woman. So various safety of medications, like whether to choose antibiotic of the acetaminophen or NSAIDs can be given because they may cause patent ductus closure or oligomnias. So the other things are whether we can antiviral like remdesivir can be given or not, and dexamethasone, what the high doses can be given or not, and aspirin can be continued, or in a respiratory distressed women whether we can give Maxel, which is eclamptic, or whether thromboembolism prophylaxis, VTE prophylaxis is required or not. And again, in ventilated patient, prone position is not suitable for the patient. So all the risks are to be considered and addressed in this woman.
You're muted.
Muted. Dr. Ashok, you're muted.
Muted.
Yes, madam, you rightly said, and one should not forget the risk of thromboembolism. That is very important in these patients now. One should be very careful and one should be observing for thromboembolism. So yes, we are clear on this, that we are managing with the COVID patient with along with our physician, and we are involving other specialty people also. And we are having a lot of problem in pregnancy when patient has COVID, and we want to avoid. We try to counsel these patients. Yes, Dr. Anju, madam. Yes, madam.
We need to divide patient into three categories: asymptomatic type in yellow and red, according to the seriousness, which has like pulse, BP, respiratory rate, and investigations, a need of oxygen and ventilation. All these things have to be seen and then managed accordingly. It is a multidisciplinary approach, definitely, with ICU care person and a physician. But we need to first see whether the patient is falling in white zone, yellow zone, or red zone. And that will really help us when we initially see and monitor the patient. That is very important for COVID patients.
Yes,
Dr.
that's
Ashok
right,
Kumar,
madam.
Dr.
Yes,
Ashok
madam.
Kumar, I want to know from your own experience, are you starting low molecular weight heparin for these patients prophylactically?
Yes. Yes,
madam. We are following, in our center, we are following along with the medicine people, and we are getting the D-dimer and inflammatory marker done in these patients because they are at a high risk. So depending on the report, of these. If the D dimers are abnormal, then we are starting them on low molecular weight heparin.
Actually, again,
Otherwise, mild patients, they are at home isolation. There, we are not giving anything.
So if the reports are normal, and if the patient has got on ultrasound, patient has got some kind of growth problem or something, then we are definitely giving them endoxifen. And even in some patients, I have given aspirin also, like when they came to me in mid-trimester, and we have followed them up, and we have been lucky that we have the babies which we delivered, they were having this end diastolic problem, and they delivered a normal baby till the end. So I have treated lots of COVID patients. I think I have treated about 26 patients of COVID during pregnancy and during the labor. And
yes,
I have seen good results. And even a line about prophylaxis, corticosteroid prophylaxis also I would like to add. It is very, very important in these patients. If the patient is beyond 28 weeks, not before 24 weeks, beyond 28 weeks, we must give them corticosteroid for the fetal lung maturity also.
Yes, madam. So now, yes, we are there to manage these patients along with our physician friends and all these. Now comes the obstetric part, like when to deliver these babies. When you want to deliver these patients in pregnancy, like if they are COVID positive, what will be your decision that and how your decision will be influenced by some factors or not. So this is the issue which we want to know. Dr. Jayashree, will you put some highlight on that?
Sure. I think all of us have had experience with managing COVID pregnant patients in the last 1 year. And looking at last April, May, if all of us were to be very honest with ourselves, there was a marked increase in the cesarean section rates because none of us knew what to do, and we were just 38 weeks go for a section.
Yes.
It was a panic reaction.
Yes, ma'am.
But as the months rolled by, we learned that there was no need to panic and that we could actually manage them as we would obstetric patients. But here the most important thing is the urgency of the birth. What is the reason for delivery versus the risk to the staff? Now we have a positive patient. If we were to deliver her now without delaying delivery, what is the risk to the people around us, to the staff who are going to be in and out of that labor room? That is the first decision to take. Now, if there is an urgent need, then we have to go ahead and induce the labor and deliver. Now, if not, now we also have to take the preferences of the mother into criteria and balance this against any fetal or obstetric indications. So as we would consider timing of delivery in anybody else, if she's positive, if she's symptomatic, she takes preference over everything else. So we need to get her back to normal. We also need to keep the staff in mind who will be actually dealing with this woman. Suppose we feel that it cannot be delayed, obstetric wise we cannot delay, then knowing that she's positive, knowing that she may be symptomatic or asymptomatic, we have to go ahead with the induction of labor versus the cesarean section protocol.
Yes,
so then it is very clear now. I think now we are all more complacent and more, not complacent is not the right word. We are happier managing these patients than we were a year ago.
Dr. Kalyani, would you like to add something, or
I had just gone down to see a COVID patient. So
yes.
My experience is that our hospital policies, we do elective cesarean section until those patients are 3 to 4 centimeter dilated. We are taking COVID patients with due risk, but as madam has says, indication or induction of labor that we are not following. Maybe we are wrong, but
okay.
In a single setup like us,
yes,
and my wife are gynecologists, there are no support system. So it's always better to go and have minimal exposure of the virus,
yes,
and because of the excessive prolonged labor, excessive exhaustion by the patient, there are risk of COVID transmission to our staff also.
Dr. Asha, please, what's your opinion on this? What are you following?
I feel that if it is obstetric indication, one should go for cesarean, but not otherwise. But the problem is that our hospital does not let us take any COVID patients. So most of the patients I'm sending to the COVID hospital, and there they all end up in cesarean because they've got one OT, they don't have labor room. And so I think it is more of an iatrogenic thing rather than, but I personally feel that if there is a hospital who can even do the vaginal delivery, there is no harm in doing vaginal delivery.
Yeah, so those are the limitations of that setup. That is a different thing. But otherwise, for obstetric indication, it should be justified. Otherwise, one can opt for vaginal delivery also in these cases. Because now what I came to know that recently a paper has come which has concluded that surgical intervention during pregnancy carries higher mortality. So probably, I don't know, that is only one paper with one study which has come. Don't know whether how far it will be translated into further, but obviously overall in journal, they say that if there is an obstetric indication, go for cesarean. Otherwise, you can opt for vaginal delivery also. Yes, Madam, Dr. Anju or Dr. Jayashree, you want to? Yes, Dr. Aruna, please. Dr. Aruna, please.
In case of severely ill patient with respiratory distress in ARDS, if she is having a 34 weeks pregnancy, what should we do? Shall we go for elective cesarean so that the maternal condition, the support to the respiratory systems and this mechanical ventilation will improve, or should we wait? And this deteriorating maternal hypoxemia can also cause fetal distress. Before worsening condition, can we do elective cesarean section in these patients?
Yes, it is open to the house.
I think it's you have to think it's a multi-system involvement. I don't think we should, for the baby's sake, put the mother at risk.
Yes.
Just, we have always been
the baby
that the mother is
the last nail.
I would like to add that we don't need to hurriedly go for cesarean. We should manage, improve her oxygen saturation, control her COVID, and then think of it, number one. And supposing we need to go, then one very important thing we should know as obstetricians, that we do not need to give them general anesthesia. Regional anesthesia in these patients is very, very important. That will be better for the mother as well as for the baby. So regional
as well as for the anesthetist.
No, I think here also there is a controversy. Some anesthetists actually seem to prefer a closed system.
Sorry. We should know, if patient is ours, we should know what is best for our patient also. So I feel that, we should know that we have to tell them not to give her general anesthesia. Regional anesthesia is always preferred. Paint her beforehand and give her minimum, do the fast surgery as Dr. Jaydeep had just said, reducing the steps, that is very important. And of course, looking at the stage of patients, if the patient is premature and if we can give her good ventilation, oxygen support, control her disease, and then deliver would be a better option. And that is what lots of cases and we have got good results with that.
Yes. So actually now the vaccine.
Difficult to operate on a moribund patient, shifting her to the OT, all those will be practical problems. Then even not only the COVID, we have seen other illnesses like H1N1, these situations have to be managed based on the setup. Sometimes it will be very difficult and it might be a perimartum cesarean section. So all
yes,
these,
madam.
These should be considered.
Yes. Okay. So
Ashok,
because now
Dr. Ashok, I hate to interrupt, but it is 9:15.
Sir, whenever you say we will stop. Sir, whenever you say we will stop.
But there are a lot of questions also, so we will need some time for the panelists to answer.
Sir, give us 5 minutes. We'll finish off this COVID, and then we will have the question answer.
Yes,
and whenever you say, we will stop it because otherwise it will go on. We have a lot of discussion to happen here. So you can let us know whenever.
Very rich discussion. I am very happy also to share that there are 5,404 delegates who have logged in for this webinar, and I'm sure all of them are quite happy and benefited by this very rich and excellent discussion going on. Please carry on.
Yes. So now we were going to the topic of vaccination because vaccination has come. Earlier we were waiting for the vaccination. Now it has come. So Dr. Asha, can you highlight or can you tell us what is the role of vaccination during pregnancy? Whether we should give, we should not give, because at the moment the government is not accepting the thing that it should be given in pregnancy, and we are not giving anybody COVID vaccination. So what is your thought on that?
See, at the moment, there is no recommendation from any of our bodies to give vaccination in pregnancy. But I was listening to JAMA discussion day before yesterday. And there in US, they have given to more than 15,000 women, they have given vaccine, and they have given mRNA vaccine. So I think we don't have this vaccine at the moment, but and there they are highly recommending, and they say that it is more important to save the pregnant woman, because whatever happens to the baby, first of all, we have to save the woman. So we have to take this risk, and after counseling, we should give the vaccine to the. So they were in high opinion of giving vaccine. So once we have some guidelines here also, I think I would also recommend vaccine, because we are already giving influenza vaccine to these women. So I think there is a point in giving corona vaccine also to COVID.
Dr. Girish, what is your opinion?
Yes, actually, sir, I too in favor of Asha Bakshi madam that we should give the vaccine, but as the Indian guidelines says that we should not give. And if you are giving it to the patient and if something goes wrong, then it can be a problem with the doctor.
No, that is acceptable.
No, I am in favor to give the vaccine to the pregnant ladies.
Yeah, because there are studies and which are evidences which has come from the West that in pregnancy and even lactating women, the vaccination is a safe option, and rather one should opt for this because the benefits are more. So
not denied to the woman. And also
only concern remains, sir, that in India we have got a permission to use at an emergency.
No, that is what I'm saying.
That is the reason.
That the point of discussion here is that yes, we know that we are not giving vaccination to the pregnant ladies as per our government guidelines. We have DCGI no approval policy on that till now. But yes, evidences are coming, and one should now try to generate the opinion that it should be the option available for pregnant ladies. So that is what the point of discussion, and this is the message which we wanted to put it forward from this discussion.
One latest data is they tested the efficacy of vaccine in pregnant women. They showed that antibodies or immunogenicity is good for the vaccine in pregnant women, and also breast milk samples and cord blood samples also contain antibodies. So that is a favorable data which is coming from the West.
Foxy should take initiative in this suggestion.
Yeah, the RCOG very clearly says that people at risk should be given. The healthcare workers, the doctors, nurses, and so I think US, as Asha said, they seem to be calling them and giving them.
Yes, yes. I have some relatives and friends ringing me up as well that should we be taking it or not, and I said you discuss with your local obstetrician, and if they are happy, go ahead.
I think that is the current practice which we have to follow.
Sir, I have read lots of papers where they have, claimed their efficacy and no risk for the mother. There are lots of papers I read about it, and they are recommending vaccine in the Western world. Yes, they are recommending.
So last point for COVID, which I wanted to discuss is that with COVID, how are you managing your antenatal care services? Whether you have adopted some changes in that, or you're doing as pre-COVID era, which you used to follow these patients regularly in the antenatal period, or you have changed. So we start with Dr. Aruna, whether you have changed or you're following the same methodology.
No, so we changed according to our FOXI guidelines. We limited the antenatal visits. We for low risk patients is only 5 visits. First one is confirmation of the pregnancy. Second one is anti-scan visit. That is around 12 to 14 weeks. There we'll do anti-scan, double marker, and the labs. That is glucose tolerance, thyroid, everything. All labs we will do around 12 to 14 weeks. If everything is normal, again the next visit will be a TIFA scan visit, around 20 to 22 weeks. There we'll do the TIFA scan. Again, we'll repeat the glucose tolerance test and labs. And if it is fine, then again we'll call the patient around 32 to 34 weeks, where we'll see the growth, amniotic fluid, everything. If it is fine, again near term, again we'll do the scan and we'll decide the delivery of the date and we'll admit for delivery.
Dr. Kalyan,
for low risk patients.
Yes, Dr. Kalyan, do you have any changes because you are doing single practice, that type of?
We are following the protocols as Dr. Aruna madam has said, but we regarding the place, we have got an underground new OPD place where we are doing this as a screening method. And secondly, we are also conducting deliveries of the COVID positive patient. So we have a separate floor where entrance is different. And on that floor, we do delivery as well as cesarean, and all rooms are equipped to take care about the COVID care specialists.
No, I just wanted to have an opinion of my panelists, whether you are following telemedicine in these cases or not. So Dr. Anju, Soni madam.
Sir, last
Yes.
pandemic, we were doing a lot of telemedicine, but now we are shifted to directly visit. Only
Okay.
5 visits.
Dr. Jayashree?
I find that personally for gynae consultations, telemedicine is very good. But obstetric, I think it's
Yes.
still hands-on would
So, yes.
So for in my practice, in between these 5 visits, we are doing telemedicine. We are asking the patient to have their BP checkup done, and they will take this telemedicine consultation in between these 5 visits. Any problem,
And most of the
every month they will
patients-
come to consultation through telemedicine platform. And to clinic, they will come these 5
Patients,
visits.
they have a BP
Dr.
instrument at home. So,
Yes.
so they are doing their own BP monitoring and everything, and they do teleconsultation, and then if there is anything, we call them.
So definitely we are reducing the antenatal visits. In between, if patient requires, we can do telemedicine, or we can discuss over phone with them, or we can counsel them over the phone. And if required, we ask the patient to visit the hospital for antenatal care. And this is probably everyone is following nowadays. And that's another thing which is important, which I think everyone should be following, is we are not using our stethoscope now from a either Deptone or some doctor we are doing, or so that we can listen to the fetal heart, or we are always doing ultrasound in the antenatal visits. I don't know, that is what is being followed. Dr. Jayashree, every time you are doing ultrasound?
No, I don't do it. We use the handheld Doppler.
Yeah, that is what I'm saying now. That is the thing which is easily available. And with that, we follow.
We got an additional NST machine in the room.
Yes.
Yes.
And we are getting the prints, and then only you are seeing the patients.
Yeah, yes. So, yes, madam.
The Doppler machine is only when the patient is in labor or when you want to do an NST for these patients, but otherwise for normal Doppler is more than enough.
Okay. Okay. So, Dr. Jaideep, to go up to COVID part, we have finished. You want us to stop, or it is your call? Please let us know.
I actually don't want you to stop, but I'm afraid, one of the things that we are very proud of in this webinar series is keeping to time. And
Yes,
I
sir.
think that is the way we respect.
That should be
all
always
the-
followed. Yes.
Okay.
No, sir,
And
we are in time. At 1 hour, we are asking you.
Absolutely. But Dr. Ashok, thank you very much for leading that absolutely fascinating discussion. I was enthralled, I must say, and such a lot of rich information has come out of it. And all the panelists, thank you so much. Asha, Dr. Aruna Kumari, Dr. Jayashree Gajrat, Dr. Radha. As I said at the beginning, this is, it's full of academic heavyweights. And the 3 committee chairs of FOGSI, what can I say? I mean, y'all are such wonderful stars on the FOGSI firmament. Thank you very much for all your efforts. My dear friend Kalyan, Girish, Dr. Anju Soni, all your enthusiastic efforts and work during this pandemic has really translated into FOGSI achieving much greater heights than I remember FOGSI being. So thank you very much to all the panelists. I know that there are some questions, and Dr. Asha Bakshi temporarily stepped behind the TV just now. I think that was one of the filters of her Zoom. And
I was trying.
also have the Vice President of Torrent with us. But I think this has been such a wonderful ending, to our webinar over here. Again, just to remind you, the webinar series of obstetrics is over. And next, on the 5th of May, we start with the Gynaec series. And like this one is called O2S, that one will be called G2Y. And we hope to cover comprehensively most of the topics in gynecology. And I do hope that all the faculty who has taken part in this series will see fit to join us for that series also. So that we are taking a 2-week break. And then on the 5th of May, again, we will start from May up to the end of October, early November. For those many months, we are planning to do 23 of the G2Y series. Priyankur, can I request you to ask the panelists some questions before we have the Vice President of Torrent concluding this quite wonderful series? I'm so delighted. I'm happy to tell you that there are 5,412 people logged in just now. And I think by any standard, that's a really overwhelming response. As I already said, we started with around 2,800 people, and it's been such a delight to watch the attendance going up as the series has progressed. Priyankur, please.
Thank you, Ashok sir, and thank you all the panelists. That was a wonderful panel. We have a few questions here. Dr. Vani ma'am from Visakhapatnam asks, what would be the criteria for admission in fever complicating pregnancy? So Ashok sir, either you or you can direct it to any of the panelists, sir, as you wish.
No, my panelists are there. They are practicing a lot now. Dr. Girish, would you like to answer?
Yeah, actually, every time the complaint or the symptom of only fever may not be an indication for admission, but there are certain conditions where that the cause of that fever, if it is going to harm either baby or to the mother, then probably there is a need of admission of that patient indoor, and then the proper evaluation of the disease should be done, proper diagnosis should be done, and proper treatment should be given to that patient if it is going to harm either mother or fetus or even the pregnancy also.
Dr. Asha, would you like to add something?
I don't have much experience about COVID patients, so.
No, not COVID, fever in pregnancy. The question is fever in pregnancy. They are asking, when will you admit?
If patient has fever, she's dehydrated and unwell, yes, one has to admit. But if it is just a low-grade fever, then we can just advise some outpatient treatment investigations, yes, and instruct her that if there is a problem, then do come, not to ignore it.
There is another question from Dr. Vani ma'am. She asks, antibiotic for cases where episiotomy is given. So what would be the specific antibiotic that you would recommend where episiotomy is given?
No antibiotic.
So that we have discussed, Dr. Priyankur, that we have discussed that in vaginal delivery, which is uncomplicated, antibiotic is not the choice. But if it is complicated, then we would like to give some antibiotic.
Correct.
And obviously, if we want to cover gram-positive and broad spectrum antibiotic may be given, maybe Cefex, you can go for Cefexin group, or we can go for ampicillin group.
Sir, one very important point, it doesn't depend upon only your hygienic condition or condition of your hospital or the condition at the time of delivery. It again depend upon the quality of that patient. Because
and patient profile, it is a patient profile.
Yes, because I am practicing in rural areas, and I know it is mandatory for us to give some or the other kind of antibiotic to our patient. Otherwise,
this is what I discussed. This is what I discussed, that that one should see.
Sir, I want to add instrumental delivery. Episiotomy, we should give antibiotics.
Already.
Yes, yes. Okay.
So the next question from Dr. Anita Rajoria ma'am from Delhi. She asks, is it safe to give gentamicin in pregnancy?
See, there are reports that with gentamicin in high doses, risk of like ototoxicity to the fetus and then manifesting in the newborn also. But if you are careful enough, and so some people avoid giving gentamicin as a policy, but in some places gentamicin is being given in the optimum dose without any side effect. Yes, with high doses, yes, there is risk to the fetus. Any further addition?
Yeah, sir, please continue.
Yes, madam, please. No, any other?
Kanamycin, it's not like canamycin and streptomycin aminoglycosides. Gentamicin is supposed to be safer than those.
Safe, yes.
But prolonged use at high doses can still can cause.
So pediatricians get upset, madam. Pediatricians get upset when you give gentamicin.
Amikacin should be avoided.
No, we discussed gentamicin not in pregnancy but in labor as one of the agents. In that situation, it is fine.
Since long years, even infective endocarditis prophylaxis also included gentamicin. So they stopped recently.
Thank you.
Okay.
Last question, Dr. Shashi Jindal from Kolkata. Ma'am asks, can we give vaccine in postpartum lactating mothers? I think she's talking about the COVID vaccine over here.
Yes.
Of course.
Yes, it can be given, though there are no guidelines at the moment. But if you think that when many a times when the patient is not immune to rubella, then after delivery you ask her to take rubella vaccine. So if you can give that vaccine, then there should not be any problem in giving COVID vaccine. But at the moment we don't have any guidelines. So we would rather avoid till we get some guidelines.
Yeah, even like rubella, even varicella zoster.
Any live vaccine should not be given during pregnancy.
Anyway, age-wise, most of them may not qualify. Age-wise, most of them may not qualify. We are still in the 45 years.
Yes, yes.
So there's one comment from Dr. Vani ma'am from Visakhapatnam. She says that they have done 400 plus COVID deliveries in their hospital and they have done cesarean only for obstetric indications, and that is good enough, as we have already discussed.
Yes, yes.
Good, congratulations.
She is from my society and she is working in Srikakulam as professor, and she has experience with COVID deliveries.
Madam, please convey our congratulations to her.
Okay. So in the end, I thank my panelists for this wonderful panel discussion with your inputs. And I think the audience have benefited with the discussion. Thank you very much. And I think on behalf of all of us, I thank Foxy and Dr. Jaideep Tank also for giving us this opportunity to discuss this panel discussion. Thank you. Thank you very much.
Thank you very much.
Thanks, Dr. Ashok Kumar, for
thanks to you, sir.
Thanks to you. And thanks a lot, Jaideep.
Thank you, Dr. Ashok. Thank you, Dr. Jaideep.
Our next masterclass, as sir has already said, is on the 5th of May. That's the G2Y masterclass, and we have another 23 webinars. And I would end by saying one very nice comment from Dr. Pranjal Sharma from Amravati. And ma'am says, O2S on Wednesday has become all-time favorite, like Binaka Geet Mala all-time hit Wednesday.
Kya baat hai?
Yes, kya baat hai.
Very nice.
And I would request now the Vice President of Torrent to kindly deliver the vote of thanks.
Thank you so much. Thank you so much. Good evening and a warm thank you to everyone for joining us today on this wonderful session of O2S Masterclass, the 22nd series. And this was the last one. So I think it was more like icing on the cake. It was exciting, enlightening, and also knowledge sharing. I'm sure all of you must have learned some new things and also got the chance to interact with the experts in the fields of obstetrics through the Q&A session. On behalf of entire team of Torrent, I would like to thank our chief guest, Dr. Sadhana Desai, eminent speaker, series convener, and the mastermind of O2S, Dr. Jaideep Tank. Thank you so much, sir. And speaker, Dr. Chamila. Series co-convener, Dr. Parikshit Tank. Series coordinator, Dr. Priyankur, Dr. Apurva, right? I mean, we also have Dr. Neharika. We have moderator, Dr. Ashok Kumar, who conducted the session today very well. We have the panelists, Dr. Radha, Dr. Jayashree Gajraj, Dr. Asha Bakshi, Dr. Kalyan Barmade, Dr. Anju Soni, Dr. Aruna Kumari, and Dr. Girish Mane, who have given us time from their busy schedule as such. This program would have been incomplete without your experience and knowledge. It has been an honor to associate with O2S Masterclass team. With your support and guidance, we shall continue to strengthen the India stand at every aspect of maternal health. Our special thanks to all the audience for making this O2S Masterclass successful. Thank you so much. Till we meet again for the G2Y Masterclass from the 5th of next month. Thank you so much and good night. Thank you.
Jaideep, one thing I want to add, Dr. Jaideep, you should make it available on Facebook so that people who missed, they should attend. That would be.
We did think of that, Dr. Anju. We didn't want to make it available for broadcast before the series got over, because that would disincentivize people from joining live. So now that the series is over, we are.
No, I was saying now you should make it available.
Yeah. So we are going to start a YouTube channel for this.
Yes.
And we are actually going to break up the videos. So the videos will be available as talks and they will be available as panels. So people who want to see each part can see, rather than them having to go through that entire 2-hour YouTube video. We'll actually be breaking it down and putting it on the broadcast.
Excellent. Yeah, that would be great. That would be great.
Jaideep sir, at the end of this series, आपके लिए कुछ 4 लाइनें सूझ रही है.
वाह वाह.
क्योंकि एक पूरी सीरीज एंड अप हो रही है ना. हजारों फूल चाहिए एक माला पिरोने के लिए, हजारों दीपक चाहिए एक आरती सजाने के लिए, हजारों बूंदे चाहिए एक समंदर बनाने के लिए. बस एक जयदीप टैंक ही काफी है पूरी सीरीज हिट करने के लिए.
No, but I must, that's very kind of you, but I must say that this has been teamwork, and I must thank my series co-convener Parikshit and the wonderful, wonderful moderators. And I make sure that I always take the name of the ladies first. So Niharika, Apurva, followed by Priyankur and Rohan. They have worked very hard for this series. And really speaking, it would not be possible without them. But, we have really enjoyed doing this series. As so many people are saying, we look forward to Wednesdays and we look forward to the chat and all the things. Thank you.
You really require a break, Jaideep Bhaiya. You really require a break of 2 weeks. You have been really, really busy these days.
Absolutely.
So much.
So, Saurabh, are we offline now?
Yeah.
No, not yet, sir.
Okay.
Thank you.
We can go.
COVID is in full